is beyond that capacity now. As I discussed last week, once the jurisdictions hit that threshold, the interventions that roll in, the 50% rollback of occupancy, is not helpful enough in itself to prevent further surge. Dallas now is at 27% of that hospitalization rate, San Antonio 23%, Houston 21%, Austin 19%. So what we need again is for our entire community to really embrace the concept that we must stay home if we can. If we have to go out, we do so in a limited fashion and only in circumstances where we can mask and distance. If everybody chooses that, if everybody decides collectively to protect this community by protecting themselves and their family, we can identify the peak, we can bring it down, and we can put our community in a better situation going into February. Right now, there is no peak identified, and that means we have more work to do. Next slide, please. This is an update of the projections from the UT Modeling Consortium. I'll note that this update does indicate some flattening of the curve. If you recall last week, it was almost a vertical line. And this means that our community is reacting. They are responding to the call to decrease risk. It still shows sustained growth. It does not identify a peak, which still means our hospital infrastructure is at risk of being overwhelmed. And again, we do believe that overwhelming our capacity is inevitable now, but we can mitigate the risk. We can determine how far we exceed by those protective actions that we take. Next slide, please. This is an update of the total hospitalizations graph. Again, we see that it's flattened out some. Last week, I was showing you a graph whose median projection indicated that we may exceed 1,500 hospitalizations by February. That has dropped down significantly, but still we expect with this graph, with the current, if the current transmission stays the same, that we will need more than 1,000 hospital beds by the 5th of February. So again, we have more work to do in flattening this curve, but certainly better than we were seeing last week. Next slide, please. This is an update of the projections for the ICU beds needed. Similarly, this is flatter than we saw last week. Right now, the median projection for exceeding capacity is in 2 days, January 14th. Again, how far we exceed that capacity depends upon how much more action we take to protect ourselves and protect our community. We really need to identify the peak soon, flatten it out, and drive the numbers down. Next slide, please. This is an update of our hospitalizations by age group, showing you the weekly hospitalizations over time. You can see that we had a decrease in the percentage of individuals hospitalized in our 70 to 79 and 80 plus age groups, but unfortunately an increase in our 60 to 69 age groups. We have also seen decreases in the percentages of our 20 to 29 age group, which is that yellow color in the middle of the slide, but increases in our 10 to 19 age group in the gray line towards the bottom of your slide. I'll talk more about that on the next slide. So you can see that we have further increases in the numbers of individuals hospitalized week over week. Fortunately, the rate of increase is dropping. So between December, the week that ended December 27th and the week that ended December 23rd, there was a 43% increase in individuals hospitalized that week. Between last week and the prior week, a 10% increase. So this is a good sign that we are flattening things out, but obviously we are still on the increase. We see a relative plateau in the numbers of individuals with a slight decrease in the 70 to 79 and 80 plus age groups. That increase that I mentioned before in the 60 to 69 age group. Unfortunately, if you look at the bottom in the gray, we've doubled our individuals in the 10 to 19 age group hospitalized, with 10 of them hospitalized last week. So again, this is a reminder that young people are not immune from severe disease. As we see disease transmit in an uncontrolled fashion across our community, we can expect to see more and more young people hospitalized from this disease. Next slide, please. Again, this is a similar graph, but based on race and ethnicity. We've talked in the past about the green line, which is our Latinx community. Again, relatively steady last week with a slight decrease. In the blue is our white non-Hispanic community. Similarly, relatively flat with a slight decrease in the percentage. We did see a significant increase in the gray line, which is our African American community, in terms of the percentage of the hospitalizations last week. Next slide, please. Again, you can see the numbers of individuals hospitalized in each race and ethnicity here. So some increases in the number of individuals in the Latinx community, 185 to 195. Similar increases in the number in our white non-Hispanic group, but the most significant increase in our African American community that's in the gray bar. Next slide, please. This is an update of our positivity week over week. The first week of January, we had a 17.9% positivity rate. You'll see that last week so far, that positivity is 16.6%. So I want to explain a little bit about why it's lower. We actually had a significant increase in the number of cases detected last week in the data set that I'm showing you here. So that's was a 17% increase in the number of cases detected. But we had a disproportionate increase in the number of tests performed. So 29% increase week over week in the number of tests, which drives down that positivity rate. This at this stage should not be that reassuring to us, because the cases are actually still on the rise. But we are doing a better job at getting people tested, which is reflected here. We saw a similar pattern after Thanksgiving when we dropped from 6.8 to 5.3%. But again, we have to focus on those protective actions to decrease actual transmission of disease. Next slide, please. This is a breakdown of that positivity by race and ethnicity. We can see, with the exception of our Native Hawaiian or Pacific Islander, that the other races and ethnicities had a decrease in the percent positivity week over week between the first and second week of January. So again, this week our Latinx community continues to outpace every other race and ethnicity in terms of positivity, which is why we are focusing efforts, in particular our vaccination efforts now, on our communities of color, to ensure that we can protect those communities that have been so disproportionately impacted throughout this pandemic. Next slide, please. Similar to our race and ethnicity graph, we've seen a slight decrease in most of our positivity rates across the age groups. Again, unfortunately, this week we see some patterns. We see a high positivity in our school-age children, 10 to 19 age group, which I'll talk more about on the subsequent slides. We're also seeing, unfortunately, high positivity in that 80-plus age group, which is going to continue to drive the demand on our hospitals and ICUs. And of course, the higher the age, the more likely that infection is to result in death as well. So we do expect to see significant increases in our deaths associated with COVID-19 due to this pattern that is sustained week over week. Next slide, please. So when we look at positivity in school-age children in Travis County, this data is from the week of 1/2 to 1/9. prior to returning to school, I made the recommendation that middle schools and high schools transition to virtual, and I'm thankful for Superintendent Elizalde's recommendation to her school population to choose virtual this week, because this is what we're seeing. High school is exceeding the community positivity 20.2%. Our middle school age students, 27%, which is a all-time high positivity for middle school students. Elementary schools age students, 19.8%, in preschool, 10%. So all of our school age groups are outpacing the community positivity rates, which is concerning for the ability to continue to protect students in the classroom. Again, prior to the Christmas break, positivity was lower. Certainly prior to Thanksgiving, positivity was much lower. As positivity increases in these age groups, as we get more and more concerned about the new variant, which is almost certainly here and a component of the trends we're seeing, as the in-person school numbers increase, it's going to be more and more difficult for us to control outbreaks at schools. So my recommendation for parents across this community is, if you can choose virtual, now is the time to choose virtual, so we can protect our school infrastructure, we can protect our educators, and give us an opportunity to get more people vaccinated and drive down these numbers prior to returning to in-person schooling. I do want to recognize that many schools, particularly our private schools, the Diocese of Austin, have chosen virtual options for the first 1 to 2 weeks heading back into the semester. That is helpful. And again, we're hopeful that more students, more parents will choose virtual education, at least for the short term, until we can identify a peak and start to drive the numbers down. Next slide, please. We can see the impact on our schools last week. 292 cases, 102 students, 187 staff had reported infections last week. We have seen clusters particularly associated with basketball, both boys and girls basketball. We have seen clusters associated with shared transportation buses. So again, we have to continue to identify where the risk is. The risk is extracurricular activities. The risk is shared transportation, either buses or carpools. The risk is also that communal dining, so cafeteria-based dining. So we encourage our school districts to mitigate risk as much as possible in those settings if they are continuing with in-person options. Next slide, please. So again, the total impact on schools is not just the cases, but the number of exposures that then need to be quarantined. Last week, almost 1,500 individuals were quarantined as a result of close contacts within the school setting. So that's about 1,200 students and 280 staff who have had to transition to virtual due to those exposures. So again, we're going to continue to struggle with this as long as we see that positivity across our community so high. Again, if we're going to prioritize schools, that means that every individual in this community has to take appropriate action to protect themselves so that we can keep our students able to learn and provide continuity of education. Next slide, please. Mayor and Council, this is an update of our dashboard for our nursing homes and long-term care facilities. 192 positive cases in the past 14 days, almost 400 in the past 28 days. Again, we're going to continue to struggle with protecting our most vulnerable in the community as long as our positivity is so high. We are grateful to the federal government and the allocation of vaccine for our nursing home, long-term care residents and staff. There's still quite a ways to go in terms of vaccinating that community, but the faster we can get there, the better we can protect these communities and certainly mitigate the impact on our hospitals, as a significant portion of these individuals who do get COVID-19 will be hospitalized or require ICU care. Next slide, please. I want to update you on our regional infusion center. So we are grateful for the partnership with the state and appreciate Governor Abbott, Chief Kidd, for providing this regional infusion center resource. So the Texas Division of Emergency Management opened this center on the 6th of January. Since then, 93 patients have been treated with monoclonal antibodies. Again, this is a therapy which helps to decrease the risk of hospitalization for those who are at the highest risk for complications and severe disease. We have a current capacity at that site of 26 infusions a day, but TDEM is working to build that capacity up to 75 a day. And this is, I just want to recognize our partners at Ascension Seton, St. David's, and Baylor Scott and White. They have come together. They have provided their allocations of monoclonal antibody therapy to this regional infusion center. They are working closely with us at APH and TDEM to ensure that we have a process which can provide a steady flow of monoclonal antibody to those who need it. There's a combination of physician referral. There's also referral directly from APH and community care to ensure that those folks who don't have regular health care have an opportunity to schedule and be treated. So I encourage folks who are positive, if they are contacted by community care, by Austin Public Health, and offered, this is a great option to help decrease the risk of severe disease, and certainly is evidence-based therapy that may be very helpful in that, and it is free of charge. Next slide, please. I also want to update the process on our Austin Travis County alternate care site. So at the end of last week, TDEM approved and has provided the initial staffing of the site through private contractors. And as of this morning, it is open for business. It is able to receive patients. And again, we are grateful to the state and to TDEM for expediting those contracts and getting the staff in place. Patients will be referred here directly from hospitals. This is not a site where individuals can show up and receive care for COVID-19. For that, they need to go to their regular physician's office, urgent care, emergency room. Once individuals are stabilized in the hospital and it's clear that they are improving, this is a place where they can be transferred to convalesce for the last, on average, 7 days, so that we can decompress some of the stress on the hospitals, which will further increase their ability to handle the more acute patients. So right now, this is designed for low acuity patients. As the infrastructure builds, they will be able to take moderate acuity patients, so individuals who need a little bit more therapy. But we are grateful for that partnership. Currently, it is staffed to care for 25 individuals with plans to ramp up from there. In the current space at the convention center, it can expand to care for 250 individuals in the current footprint. We do have the ability to expand to almost 1,000 if we need it. But I want to be very clear. Our hope is that we never see a patient in this site, and that will indicate that we as a community have driven down the positivity enough to decompress our hospitals. But unfortunately, at this stage, our expectation is that we will receive patients. I want to say that the group that is staffing this, the physicians and other support staff, also staffed the alternate care site in El Paso and Harlingen. So they are experienced with COVID-19 and the alternate care site setting, which will be a great benefit to us in Austin and Travis County. Next slide, please. So again, Mayor and Council, we remain at stage 5, which means we all need to stay home if we can, work from home if we can, educate from home if we can. The more we embrace this concept, the more likely we are to drive down those cases and put our hospitals in a better situation and ultimately save lives. Next slide, please. For those like me who have trouble with the small print, the stage 5, again, no gatherings with anybody outside of your household. Dining and shopping should be limited to essential trips and preferably takeaway and delivery or drive-through only. Non-essential travel should be avoided. And again, businesses are, while they're capable through the governor's order, GA 32, of being open to 50%, we strongly encourage them to transition to drive-through, curbside, or delivery only. And with that, I will transition over to Director Hayden to speak on vaccines.
Thank you, Dr. Escott. If you could transition to the next slide, that will be helpful. So I'm going to spend some time to provide the vaccine update. I think it is also going to be important for us to also cover some of the other information as well within this vaccine update. So I will provide some information on what's happening with our schools, our long-term care, as well as our homeless population. Next slide, please. So this is a community vaccination strategy. And so this is, we sent out the plan last week, and this was in the plan. That plan is a draft plan. We are seeking feedback from the public. We will be hosting 2 community meetings this week on the 13th and 14th. And so you should have received information about that through a release yesterday. And so with this plan, the goal is that we definitely want to make sure that we secure the health infrastructure and be able to protect those who may end up having severe illness, including death. And so our focus, as you can see in the middle of this document, is that we want to focus on the hardest hit communities, definitely focusing on communities of color, low income, and older adults. One of the things I'd like to share is with our long-term care facilities, they are working directly with CVS and Walgreens. As of the 9th of this month, 42 facilities have received their vaccines. And so CVS and Walgreens will provide their first and their booster vaccine dose. And so 7,000 residents have received that vaccine in our community. And so CVS and Walgreens will continue to provide that service. And so as new staff and residents are in those facilities, they're going to go back and provide the first and the second dose to them. And so as a community, we have to emphasize the best way for us to making sure that our long-term care facilities, our healthcare infrastructure, which are all of our 1As, are definitely covered during this process with our vaccines. Then we want to make sure to address folks that are severely ill and may have died because of it. Next slide. We know that it is important for us to address the equity gaps in the vaccine administration. I'm sure that most of you have seen or read information about where the providers are in Austin and Travis County. As I shared with you in the memo, Austin Public Health is not a distributor. We do not enroll individuals to provide the vaccine to their populations. We are a provider. And so knowing that we are a provider and we are looking at the data of where the locations are, where the providers are, we have to be able to fill in the gaps. And so as we are working to make sure that we fill in the gaps, our focus will be on populations that are disproportionately affected by severe disease and death, which will include our populations of color, those living in poverty, those living in areas where the disease transmission is the highest, and we are definitely looking at areas where there is not a lot of transportation access. It's important for us, you know, we're excited about the bond, but we know that for us to be able to make sure that we are covering the areas where people need it the most, we have to be able to consider transportation in the process. Our goal as we continue to stand up sites is starting with a large scale distribution site, which has the ability to provide several vaccines a day, and then also have smaller providers in areas. And so those areas that the city is focusing on is going to be the Eastern Crescent. And so kind of looking at City of Austin and Travis County, you know, from the southeast, you know, to the northeast side of the city and county. We definitely want to coordinate our vaccine administrators with others because we know that, you know, we are a safety net. So as most of you may recall, with the vaccines, with the testing, we looked at areas where that fit the same footprint, where we were seeing an increase in with the highest disease transmission was the highest. And so that's where we look to have our sites where folks will have a location in their community that they can easily access those. And so as we are meeting with partners and having conversations, we're definitely receiving feedback from our community partners about how we can definitely have locations and working with partners to maximize our efforts. Next slide, please. As you are aware of, we initially, through our public safety and wellness, received 1,300 doses initially. And so those were 1A EMS, AFD, and then APD. And then APH received our 1,300 doses. And so basically what we've been able to do with all of those doses is we focused on 1A, but we also were alerted that there was one long-term care facility. And so we have partnered with them to be able to make sure that they were covered with vaccines, including the residents and the staff. And so on yesterday morning at 10 a.m., the department did receive 12,000 doses of vaccine. We are operating 3 Monday, Tuesday, Wednesday. These are closed pods. We are completing with 1A during this time, but we are also partnering with community care, People's Clinic, and Lone Star Circle of Care, because our goal is that we know that in these populations, this is where the safety net, where most folks go that are uninsured and underinsured. And so our focus for those 3 days, Monday, Tuesday, and Wednesday, including the 1A, we'll continue to provide that service. It is an appointment-only process, and so if folks, you know, lack access to the internet, we ask them just to, you know, reach out to 311, and then we will get them connected so we can schedule them for an appointment. On tomorrow, our portal will be live for the public, and so we will continue to complete the rest of this 12,000 vaccine. And we're just letting everyone know we do not have enough vaccine, but we are just asking people to be patient with us through this process. The portal will be live tomorrow, and so they can go in and they can register. It will be the same as they have for testing. They would go to our site, they would register on that site, and then from there they will receive a confirmation email from our system. And so the department made the decision to go with Salesforce. We have already been working with Salesforce during this time, throughout this pandemic. And so we only wanted to use one system. And so everyone that goes into that system tomorrow, that will be a part of our Salesforce access. And then also, again, just as a reminder for folks that don't have that access, we're asking you to call 311 and our staff will work with you. One of the other things that we are, really emphasizing to larger employers, if they can connect with their wellness partner, a lot of large employers, for example, like the city of Austin, we have partnered with Randall's in the past to provide our flu vaccines, and we are encouraging other large providers to definitely reach out and talk with them about that being a process for you with your employees through your insurance. And so I just wanted to emphasize that as well today. Next slide. One of the things that we have started having some discussions about, definitely wanting to have more discussions about it, is that Dishes would like to have a regional hub and spoke process where partners will be willing to have the hub and be able to have kind of spoke locations. So whether you have smaller locations, you're working across your region, with neighboring counties. And so we have began those conversations about what that could potentially look like for our community as well as our neighboring communities. And so we will provide more information about that. We've reached out to CapCog, and so they are going to assist us to bring some people together to have those conversations. And so as this initial pilot moves forward, our goal is to provide all of the vaccine out this week. And then our hope is that we can receive confirmation that we will be able to depend on at least between 2,000 to 10,000 doses of vaccine to be moving between us and our partners here in Travis County, but then potentially across the region. The other thing, this is my last slide for that, but I did want to just kind of remind folks that for the homeless population, we are continuing to work with our protective lodges. Our staff have transitioned 131 people have been housed from our protective lodges. 62 of those happened in the month of December. We are continuing with our meals. We've provided over 70,000 meals, and we are continuing with our mobile showers. With our long-term care facility, as Dr. Escott shared with you, we are continuing to see an increase in cases in long-term care facilities. And so our incident command team has sent out a strike team to work in one of the locations. We're continuing to provide testing at those sites, and we are recommending that testing happens every 3 to 7 days in those facilities. And so I just wanted to remind folks that all of those efforts in the long-term care facilities are continuing. One of the other things I wanted to also share is that we have 4 post-acute care isolation facilities for long-term care residents. And so that really works well with the facilities because they're able to use that isolation facility as they need it. And so at that time, I'm going to close my report and I'm available for questions. Thank you very much.
Thank you, Director Hayden. I'll turn it back to the mayor for opening up for questions.
Thank you, Manager. And again, thanks for this work. If you need anything or support to make sure the vaccinations get out, please make sure that you ask. And obviously, that's real important that we get that done. Again, thanks to the state for 3 things this week: the allocation numbers that hopefully we can then get out. The second is that infusion center that was stood up the first week in January. Just to reiterate, that's the treatment that the president got. And it's available in our community for free for people that qualify for that. We've stood up the infusion center on the east side of town to make it available. And there's going to be additional capacity for the infusion center in the alternate care site as well. And in that regard, we're probably delivering and getting out and have greater capacity for that therapeutic than anybody else does in Texas because of the cooperation of our systems, hospital systems, with the standing up of those centers. So thank you to the 3 hospital systems on that. And then the last thing that we thank the state for this week is the staffing, not only for the infusion center, but also for the alternate care site. Which is being stood up with staffing from the state, which was critical because if we had to staff it ourselves, then we would be taking staffing away from hospitals or local staffing that was otherwise available to hospitals with respect to their surges in the hospitals. I have 3 quick questions, and then I'm going to turn it over to colleagues. Tell me, Director Hayden, what are we doing in the city with respect to communications or campaigns regarding vaccine confidence?
We just recently closed a mini grant process that we are going to have contractors that are going to be working with us to, 1, address any hesitancy that folks may have to provide the education to them. These are grassroots organizations that will be able to work with folks in targeted zip codes to really work very closely with them. In addition to that, we are understanding that there's also some hesitancy in long-term care facilities. And so our staff have got together to provide a video that we have shared with our long-term care facilities as well. And then lastly, we have a couple of partners that we have been reaching out to and meeting regularly with to be able to provide us feedback into potential areas of where we may want to also consider hard to reach individuals.
Okay. With respect to the sign up this week, heretofore it's been real difficult to sign up for the vaccine because you had to do it to individual providers of the vaccine. So we had people that were trying to sign up on an HEB site, on a CVS site, on a clinic site, and frustrating for them and with a lack of actual supply, frustrating on lots of levels. But you're standing up a site this week where people can go in and sign up the same way they sign up for testing through APH, that same dashboard. Will that site last beyond this week and the 12,000?
Yes, it will.
And is it possible that site, as it evolves and as it works out, can be more of a central source for people to go to sign up for vaccines administration in multiple places, multiple providers around the city?
So that is a part of the conversations that we are having with the other providers outside of the city of Austin and Travis County. Right now we have partners that had already been a part of Salesforce in Williamson County and Bastrop County. And so the goal would be is that we would want the other counties to become a part of that system as well. I think one of the other things that we are also having discussions about is a regional hub where folks can really see, this is a place where I can sign up, but then these are also other locations if I decide I don't want to go to, coming in through the city's city-county regional hub, but it will provide that information as well.
Okay, the degree to which we can centralize that so that people don't have to go to multiple places, but go to one place and still be able to access the vaccine in multiple places when their first opportunity arises, I think will be real important, especially as we're trying to get this vaccine out to hundreds of thousands of people over time. So thanks for your work on that. And then the last question I have relates to dashboard. How do we get transparent information out to the community about the number of people that are getting the vaccine, who's getting the vaccine, the demographic information associated with the people getting the vaccine? Do we control that information? Is there a way for us to make that information available?
What we will be able to provide right now is what Austin Public Health is doing. We cannot go beyond that. The state of Texas has a dashboard, that they are working on to stand up. And so what we will be able to initially be able to provide is what Austin Public Health is doing. For example, yesterday we were able to provide 850 vaccines yesterday at that location. And so our staff are going to compile a report that we will be able to share, and then we will post it on our website, which will show the number of vaccines we provided, and it will include the demographic data. And so as more information becomes available, as we continue to work with our partners to be able to have them to share that information as well, then the dashboard will grow. But initially, that information will be Austin Public Health only.
Thank you. Colleagues, I think Paige had her hand raised.
I did. Thank you, Mayor. I have questions for Dr. Escott and Director Hayden, but I'll start with Dr. Escott since I know he may have to leave the meeting a little sooner. The alternate care site, can you talk a little bit more about that? Is it going to be people who have recovered or are mostly recovered? This is not a walk up and get an assessment type of facility at this point, right?
That's correct, council member. This is for individuals who have been seen in the hospital, have been stabilized, and who are in the process of recovery, enough so that they can be safely moved to a lower level of care. These are individuals who may still require some oxygen administration. They may require some help with medications or other things, but this is not. These will not be individuals who need ICU level care or those higher levels of care that really need to be done in the hospital. There is no avenue for folks to walk up. If somebody walks up to the site, they'll find that it's going to be locked down. It's not open to the public. So there are mechanisms in place if that does happen. Ambulance will be called out to help that individual. But this is the model that has been used in El Paso. The model has been used in Harlingen, and most other alternate care sites around the state. So we're confident in this model and hopeful that it will help decrease the burden on the hospitals right now.
Thank you for that clarification. I remember hearing that a couple of months ago when a few of us were able to get a tour, and just wanted to make sure that was still the case. I did notice on your chart about the ISDs reporting cases, I didn't see Eanes ISD on the list. Is that just that they didn't send the information, or they didn't have any?
Councilman, I imagine it's because a report was not submitted. I can get with our school's task force and see if there's any updates on that. But that particular report relies on that reporting to our school nurse line to report those cases and exposures.
Okay, that information would be helpful, just because I know in previous iterations of charts like this, it had shown up with some cases of individuals in the school. Can you talk a little bit more about the age group of under 1-year-olds? Why we would see more infants contracting COVID? Is that because of daycares or a new strain affecting different age groups differently? Can you tell me a little bit more about that?
Councilmember, I think the issue that we're seeing here, and why we're seeing younger age groups increasingly impacted, is because we have massive uncontrolled spread of disease. So we're going to expect increased numbers in all age groups. One reason why the percentage of infants may be higher is because, if they are symptomatic, they're going to get tested. We're not going to find a lot of asymptomatic babies going off and getting COVID-19 testing. So I think the risk of COVID-19 exposure in people who are symptomatic, including infants, is going to be higher than the risk across the board if you lump in asymptomatic individuals.
Okay, and so this new strain that is in all likelihood here, have you noticed any trends or any predictions that can be made if it is affecting anyone differently, or if there's any different symptoms that people should be aware of?
So the information that we have so far from the federal government and other folks is that it doesn't appear to be any more dangerous in terms of the intensity of its symptoms or the severity of the illness that results. There is concern that it is more easily contracted, which is going to make it more difficult for us to control this uncontrolled outbreak that we're experiencing now. Again, when the disease transitions or mutates in a way that makes it easier to contract, it also makes us more concerned about the potential for environmental impacts, including making it easier for airborne transmission to be possible. We don't have clear evidence of that now, but we suspect that may be the case, which is why in particular we're concerned more about schools and other settings where individuals are in close proximity for a duration of time.
Thank you. That's all I had for Dr. Escott. I have a few more for Director Hayden, but I'm happy to let other people go first.
That sounds good. We'll come back to you for Director Hayden questions, and let's limit the questions right now to Dr. Escott. Councilmember Kitchen.
I have a number of questions about seniors and about reaching them, as well as about but I'm not sure if these are for Dr. Escott or for Director Hayden, so I'll go ahead and ask them, and I will limit my questions right now to my questions about seniors so that others can ask questions too. So my question really boils down to seniors, two aspects. Seniors who are living in long-term care facilities that don't have a vaccine relationship with VCS or CVS or Walgreens. My first question is, my understanding was that there are some long-term care facilities that are not covered by the federal program. Can you speak to that? Is that true? And how are we reaching those?
So what we have put in place is for those that were not covered by the federal program, the office has been providing some level of support until last week. And so they've let us know that any of the facilities that remain would need to be picked up by Austin Public Health. And so that is what we started to do. And so folks can just reach out to us on our, at our nursing home information line if they have any questions or concerns. And we will have our team to see what they need, and we can provide those vaccines to them and their staff.
Okay, let me ask more specifically then. How many of our long-term care facilities in our community are not covered by the federal vaccine program?
To my knowledge, my staff have only told me about 2.
Okay.
Until they come forward and say, because we typically would look at the report that the state sends us, and we, reach out to HHSC to say, it looks like this group is not on there, and then our staff, incident command folks, will reach out to the administrators. So right now, there are 2 that we know of. There could be more, and so as they reach out to us and we continue to try to true up what the state sends us about who's on that list and who has received those, then we can reach out to those.
Okay, so let me make sure I understood. So we are proactively comparing the list of our long-term care facilities in our community with the list of those facilities that are included in the Walgreens and CVS system. Is that
Yes.
right?
What the way?
In other words, we're not waiting for them to reach out to us. We've identified which ones are not part of that program.
So we've done a couple of things, because the way the system with the state is they provide us a list of who they are working with and who has been providing the vaccines, have already started to receive those. And so our folks are being proactive to say, if there's others, then we need to work with them. And so thus far we found 2. We will continue that process with the state and the long-term care facilities through our incident command structure.
Okay, then the last question I have, and then I'll turn it over to others, that relates to seniors then, is that, our minority population, our Latino senior citizens, a lot of them live at home with families, for example, and seniors living in our community at home. So how are we proactively reaching out to them? I am concerned that I'm very pleased and I appreciate the setting up the portal. I think that's very helpful. But I'm very concerned about how we're going to proactively reach out to seniors, particularly low-income seniors, minority seniors, because I don't know that they are going to either know or know how to or be able to access a portal. So I'm wanting to understand how we're reaching out to them. And one of the reasons I'm asking that question is, we did work early on last summer. The staff helped a number of our offices to do phone calls and to send postcards to seniors that were living at home in our districts. And that was one way we outreach to them proactively. So my question to you is how, and I understand, of course, that we don't yet have enough for everyone in our community, but what are we going to do to proactively reach out to those seniors that are living with families or living on their own in the community?
We've already started a few things. One, as you know, we have an employee in the department, Tabitha Taylor, that works with the Commission on Seniors. And so she has been a part of the conversation. As we outreach to those populations, we have a couple of the providers that are a part of the Vaccine Coalition Task Force. So there are members there. So they have been emailing us, and we've been communicating with them as well. And so we will definitely work with folks that we have contracts with to be able to get the word out through the populations that they serve. And then we have some other partners that are willing to be able to get the information out to those populations. So we do have that on our radar. Those things are underway and will continue throughout this process. As we have more vaccine available, as you know, we've done some in-home testing. And so that's another part of our strategy that we would like to implement to be able to provide some vaccine, to be able to provide the vaccine at home to them. So those are the things that we're looking at. We are always open to, any list that you all may have. And we've said that to the community as well. We also know that Parks and Recreation also has folks that they've worked with, so we'll be working with them as well.
Okay, thank you very much. I appreciate it. I will work with Tabitha in your office. I think I would like to suggest that we think about ways to be proactive. For example, we could easily, and it's not expensive and it's fast, to do phone calls, to do recorded phone calls to seniors, for example, to send a postcard. I really think that because we're not, obviously, and I know you guys are preparing for, and I appreciate this, for vaccine distribution over a number of months. We're not just talking about what's immediately available to us, because it's going to take a while to have enough. But we need to be letting people know right now. And that's, there are other populations too, but that is one of the populations that is likely not to have, that they may not have as much access, and they may not either to information or to the vaccines. And so I really urge us to be proactive, and I'm happy to work with Tabitha's office as we did earlier in the year when we were reaching out to seniors. Thank you.
And just a reminder, for seniors, but other people that don't have access, we will continue to have the ability to sign up individuals that don't have access to the internet and may not, be able to access and go online to our portal. So that will continue to be a resource available for our seniors, but just the kind of the general population that don't have access.
Thank you. Councilmember Fuentes.
Yes, thank you. So a lot of my questions have been covered, and Councilmember Kitchen, I'm right there with you, really looking at and acknowledging that culturally for Latinos, a lot of Latinos are not in long-term facilities, or not in nursing homes. We keep our abuelos in our homes, and so it's intergenerational. And so I definitely want to make sure that we have a strategy in place to ensure that we're reaching out to our vulnerable populations. One of the questions I had, Director Hayden, was around I just want to clarify. So APH, with the 12,000 doses that were received this week, those 12,000 are first going to go to individuals in the 1A group. Do we know when the majority of the 1A folks in long-term facility group, when we'll have vaccinated the majority of 1A?
Well, our goal really, just as a community, not just Austin Public Health, we're really trying to finish the 1A by the end of this week. And so not just Austin Public Health, but all of the other partners that are providing vaccines, our goal is to try to finish that 1A this week.
Okay, so then will we be vaccinating folks in the 1B category this week with that 12,000 dose allotment? Yes.
We have already started some 1Bs. We are definitely targeting 65 years of age or older are the folks that we are really trying to make sure that, that we are focusing on that area. But yes, we are transitioning to 1B. So some 1Bs will be a part of the 12,000.
So part of APH, our department's equity efforts include the actual physical location of the mass vaccine sites that we're standing up this week. And those locations will be disclosed tomorrow when folks go up to sign up on the registration page.
Yes, when individuals register for the vaccine, when they receive the information back about, the time that they can go, and it will provide them the location.
And can you also just elaborate a little bit more on what else we are doing with our equity efforts? So part of the equity, of course, is ensuring that we're being equitable in the physical locations that we're selecting. But what else is our public health department doing in terms of equity?
Well, there's several things that we've done, really even before the pandemic hit. The department has a health equity and community engagement division. Within that division, we have focused in with the Asian population as well as Hispanic and African American communities to address health disparities. And so with our equity efforts, we have a priority population group that has been stood up since the inception of this process. And so we have worked with community partners to identify specific locations that we have provided services to. So whether it has been financial assistance, whether it's been testing in those communities, or whether it has been us working very closely in those communities to provide our community groups with PPE so they can disseminate into the community. But that's just a high-level list. In addition to that, from a communications perspective, we have worked very closely with our media outlets. We have held some Facebook Live, Spanish-speaking only sessions with the community, as well as providing outreach material. Our information on our website is in English and Spanish and several other languages. And so the goal is to ensure that the information that we are providing to the community is culturally relevant, so we can ensure that we are reaching, all of the populations that we need to reach with our information, outreach, and education.
Thank you.
Great, thank you. Kathy, and then Greg.
Thanks very much for this information. I have a few questions, some of which I think I'll just submit after this session, but I also want to go back to a couple of the points that my colleagues made. I want to echo many of the people who have written are encouraging the city and the county to set up the kind of portal that I think it was the mayor first described. I know you don't necessarily have control over whether other agencies and organizations will participate in that, but to the extent that we could that the city could provide a database along the way, a dashboard rather, along the lines of what you have done for COVID cases, that would be enormously helpful to be able to track where the vaccine has been distributed and to whom. The other thing that we are hearing is happening in some other places that I think one of my colleagues also mentioned is that kind of central database of information that provide about real-time information about vaccine availability and wait list opportunities. And so as I understood, I think this might have been the mayor's question, but Director Hayden, did you say there might be an opportunity in the weeks ahead to have a central community registration process for individuals waiting for vaccines? Not just vaccines through APH, but vaccines through clinics and HEB and various pharmacies.
So we have begun those initial conversations It is definitely not something that will happen in the next week or so, because basically what we need to be able to do is pull together folks on the regional level, have those conversations. Our vaccine distribution group did include regional partners. We have been working with them regionally throughout this process. And so in order for you to have something elaborate where we pick up all 350 of those partners, each of them have to be willing to work together with Austin Public Health and in our community and develop a regional approach. And so those are the initial conversations that we are having to see how we can approach this through regional lens. And so it definitely will take everyone to be on board. We have to define what this region will look like, whether we're going to go with MSA or whether we would be going with a larger area of 11 counties that, work with CAPCOG. And so all of those discussions will have to take place and then determine exactly how we would maybe move forward with a regional approach.
And so both of those initiatives would require that same regional approach for the dashboard showing where the vaccine has been distributed community-wide, as well as some kind of regional sign-up system. Both of those would require that. I wonder to what extent will the infrastructure you already built to track cases in this area at least help with a dashboard about vaccine distribution?
Well, we currently use Salesforce, and several of the partners are using Salesforce with us. And as you know, at the state level, the state is also using that Salesforce system as well. And so different partners are using different systems. We're all not using the same system. So there's quite a bit of things that would need to be worked out to determine, how we will pull all of this together.
And so several of my colleagues have also referenced individuals who are not part of a long-term care facility, who are living at home. I know all of our offices are hearing from individuals who are seeking information about vaccines, and they may be in that 1B group. I want to echo what Councilmember Kitchen said. Several of our offices did have really good outreach to seniors in our districts, largely through volunteer efforts, and so we can tap into those resources again if it's helpful to you. I'm not sure what a postcard at this moment would say, though, because many of those individuals who are calling or are emailing us are calling the list of providers that are on the state, and there's not real-time data there in terms of availability. So they're calling, multiple sources and finding no vaccine, and they likely won't qualify for insurance. They would not be eligible for the public health distribution. So what can you give us some words of advice or some sense of when Austin Public Health might be able to give us a timeline? I think we need to we probably need to reset some of the expectations in the community about how quickly the vaccine will be available on a wide enough scale to get individuals in that 1B category who won't qualify for the 12,000 doses that Austin Public Health has this week or in the weeks ahead. What would you advise them to do in terms of seeking out a vaccine source?
Yeah, I think it's going to be really important that folks just think about initially within the state's plan. The state's plan really, laid out, and I know there's been questions about when this would happen and is this subject to change. Everything is definitely subject to change. But within that initial plan that the state of Texas released, they stated that, December, January there will not be a significant amount of vaccine coming into communities. And so we understand at the federal level that there was definitely a delay. We were anticipating that at least 20 million vaccines will be able to be distributed at the end of December and January, across the U.S. That did not happen, only 5 million of them. And so we really got to, and I understand, I wholeheartedly understand, and we want to be able to get this out as soon as we can. But we've got to be realistic to know that if things are coming from the federal level, we're in a process of transitioning administration. And so they have communicated that that's going to be a primary project for them. And so as more vaccine becomes available that is being shipped to the various areas, we can anticipate that it will probably be around the April timeframe where we will be able to see more vaccine. That's an estimate, but that is probably the best estimate that I can provide where we will see it more widely available. In the meantime, we're still encouraging folks, even the folks that have received their vaccine, to continue to, wear their masks, stay home, and, definitely the social distancing, washing your hands. We cannot emphasize that. Even for the people that have already received their vaccine, you should continue to be doing that.
Thank you very much for that. Yeah.
If I could just add on to that, I agree with what the governor said yesterday. It is a remarkable feat that we've provided as many vaccinations as we had in this state and across the country. But it's important to remember that part of the reason why vaccine effort is slow is because the same people who do vaccines are participating in massive amounts of testing and caring for massive numbers of individuals in our hospitals. I think the best thing we can do for our vaccination effort is to slow the spread of disease, free up those resources to be able to get more vaccines in the arms of people in Central Texas. I also believe that President-elect Biden has indicated a shift in policy, which is likely to mean that the vaccine which is being held back for second doses will be freely flowing. So I think we can expect in the 2-week time frame that we may see a massive injection, sorry for the pun, of additional vaccinations available across the United States.
Thank you for that. That is really extremely valuable information. I have just one last question, but I want to just say thank you for the tremendous effort that you're doing to get the vaccine out and to educate the community about the importance of it, as well as the importance of what you said, Dr. Escott, of making sure to continue to stem the spread. Could you address, please, what the process would be for vaccinating individual service providers who are working with individuals experiencing homelessness, as well as individuals within our pro lodges who might fall into that 1B category?
We have included some of the homeless service providers in the 1A category in consultation with the state. Because of the level of risk that they take as they're working with our homeless population. So we have already provided some vaccines to them. Our plan as far as what we've done thus far with the testing is we're going to be working with UT Dale Med Community Care. As you are aware that they have been providing testing in downtown shelters as well as encampments. And so we're going to be working with them so we can address the homeless population in our community and also pick up, any other additional folks that we may have not been able to add to the list. So that is underway. Those discussions are underway.
Thank you very much.
Okay. Greg, and then Leslie, and then Mackenzie. Priority questions would be questions for Dr. Escott, who we're going to lose here momentarily. Greg?
I think that my questions are primarily for Director Hayden.
Okay.
So if folks want to hop in for Dr. Escott, I'm happy to yield.
Let's do that. Does anybody have any questions for Dr. Escott before he leaves? Leslie?
Thanks. Yeah, Dr. Escott, thanks so much. I wanted to ask you a little bit more about the expectation that when President-elect Biden takes office in 8 days, he has indicated that he will change a couple of things about what actually he will make things happen in a more logical and efficient way than we have experienced for nearly a year. One of them is not holding back a stockpile for the second jab, but the other one is actually to have some direction and consistency and standards coming from the federal level so that from state to state and municipality to municipality, there is not this confusion and chaos that is in large part driving the anxiety that's in our community because people don't know why or how we are handling our vaccine and the administration of the jabs, because it's different everywhere. Can you give us a little bit more from your conversations? I know you're having state level and federal level conversations, including with the CDC. And I understand also that Dr. Fauci will be continuing as the COVID advisor, special advisor to President Biden.
Yes, Council Member. I think that there is wisdom in releasing the vaccine. There is confidence that the vaccine manufacturers will be able to deliver subsequent doses in a timely fashion in order to get those second doses in. So I think what we're likely to see, and certainly the conversations we've been having with our colleagues across the country, is that what we're likely to see is a transition away from priority-based groups in favor of a get people vaccinated push. We have seen this happen with vaccination efforts in the past. In fact, there is quite a bit of evidence that will support trying to get as much vaccine out into as many arms as possible. I'm happy that we are prioritizing the groups right now, particularly those who are frontline healthcare workers and those who are most likely to end up in the hospital. But any vaccination of any person in this community is better than it sitting on a shelf.
To follow up on,
yeah.
Right. And so to follow up on that change to approach, I wanted to ask, because I assume the answer is yes, and maybe you can give us a little bit of a glimpse behind the scenes. What are you and your staff doing in order to prepare for what looks like a change in the strategy and a more widespread and comprehensive administration of the vaccine?
Well, I'll start that response, and Director Hayden may want to add, but through Austin Public Health alone, we can do 3,000 to 4,000 a day with the current setup that we have generated for this first effort. We have groups and great partners like HEB, who today, if they had 4,000 a day, could deliver 4,000 vaccines a day. We have great partners like Austin Regional Clinic, Community Care, and others who can do thousands and thousands of vaccines every day. Again, we also have our healthcare systems that, if we can slow the spread of disease, can also ramp up massive efforts to do that as well. I think our community is focused. I think our community has demonstrated for the past 11 months that we are willing to work together hard to achieve goals, and I think the vaccine effort will be no different.
And then the last thing I wanted just to add in this, I understand that there is an operation underway to create at-home testing kits so that people can get like 20 testing 20 tests in a container so they can keep track of their own positivity rate or negativity rate, and then that can more strategically focus people on staying safe and quarantining, so that we all take the responsibility individually to test ourselves maybe every 3 days or so that we know, and this will help when we hope people can go back to work in their work spaces. We will know ourselves what our positivity or negativity rate is, and then we'll be able to have personal responsibility on what risks or not risks that we take going forward once everybody, as we move through 2021. You've heard of that too, I imagine.
I have, and I think that there are certainly particular folks in the community where that is even more important. We've made a recommendation for proactive testing for our student athletes, certainly healthcare workers who may not yet be vaccinated, individuals who by the nature of their work or their study have to be in close proximity to one another, or they have to do their work without a mask on. For those individuals in particular, that proactive testing is going to help to limit the spread.
Thank you.
Further questions for Dr. Escott? Councilmember Alter? Actually, I called in order. Let me go to McKinsey. If you have questions for Dr. Escott, we'll come back for it. Director Hayden.
Thank you, Dr. Escott and Stephanie, for being here today and for meeting with me yesterday. I noticed through the presentation we did not talk about the financial impact of the opening of the alternate care site. Could you please briefly review with the council what we talked about yesterday in our meeting?
Director Hayden still on?
I'm here. Are you asking about the alternative care site, or are you asking about, is that what your question is?
Yes, if you could talk about that, that would be great. And if it's for Director Hayden, then it can wait.
Well, I think the biggest impact, as we've shared, is that the state of Texas is going to provide a team to come down and to operate that facility for us. And so we are very grateful to receive that team to come in to provide those services. I think, any other physical impact, definitely would be because of the use of the facility with any other, overhead costs would definitely be something that the city would definitely work through with the budget office.
And Councilmember, I will say that as we discussed yesterday, the idea for this center is a regional center. Right now we're focusing on the MSA, but it certainly has the potential to provide services for 11 counties or for the entirety of Region 7. In that circumstance, I think there does need to be cooperation from other jurisdictions to help support the cost of that, at least the local jurisdiction's share of that expense.
Thank you.
Okay. Councilmember Alter, and then Councilmember Harper Madison.
Thank you. My colleagues have answered a number of the questions that I had. I will have some later for Director Hayden on vaccines. But I did want to ask Dr. Escott if you could speak a little bit more about the clusters that we're seeing in our schools. It's been striking the request that we're getting to choose virtual at the same time that varsity sports are continuing. Can you help us understand why that is continuing? I believe it's because the governor has orders allow that. But it would be helpful for parents to have more information about the clusters. We don't get that information unless our child is exposed. All we get is that there's been a case at the school. But if there have been clusters with other teams, you don't really know about that. So can you provide a little bit more information for the community on that?
Councilmember, similar to what we saw in the fall with football, we're seeing clusters with basketball. We can expect to see clusters in other sports, winter and spring sports as well. This is why we provided the advice that extracurricular activities be canceled or postponed. And if they weren't canceled or postponed, that they implement proactive testing to try to avoid the cluster situation. Austin Public Health has free testing available. Student athletes and others could be tested weekly, twice weekly. They also have partnerships and availability of Buy Now testing for the state for that proactive testing effort. Again, it's not surprising we're seeing clusters in athletics. We have events where distancing is not possible and masking may not always be possible. That's in particular why we recommended they be suspended or postponed. We've got to continue to identify where the risk is and reduce that risk. So again, I think it's important for parents to understand, and we provided this direction over the summer. If your student is involved in one of those activities where masking and distancing aren't possible, there's an increased likelihood of becoming COVID-19 positive for that student athlete and for that household as well.
Thank you. And then as follow-up, are we anticipating any changes to our recreational access as we currently have it, whether it's pools or escapes or any kind of activities that we are running at this point?
So we meet regularly with Parks and Recreation. I'm satisfied with the current level of opening. Most of the facilities that are open to a maximum capacity of 25%. Many of the places actually are only achieving about 5% of occupancy. And there's a fine balance between creating opportunities for people to gather with, providing opportunities for people to be outside rather than inside. Right now, we are concerned about people being inside too much with the cooler weather. So our desire right now is to keep those things open, but managing the risk by controlling the occupancy.
Thank you.
Okay, Vanessa?
Yes, I have a question for Dr. Escott. I noticed over the weekend when we were doing the pilot vaccination distribution that one of the questions on the form is folks have to indicate whether or not they've had the virus within the last 90 days. And so can you speak to a little bit, if someone has tested positive for the virus, can they still get the vaccine, or is the efficacy of the vaccine diluted? Like what should we know to best prepare people and inform people about you've tested positive for the vaccine, however, you can still get the vaccine? Or I know like the best practice is to wait, but if they're on site, they've showed up for the distribution and they've just shared with us, hey, we've tested positive in the last 90 days. What do we do in that scenario?
So people who have had COVID can certainly get the vaccine. That is recommended. We definitely don't want people who are still under quarantine or sick from COVID-19 due to the risk of exposure. The reason for the 90 days is because we have good evidence that people who've had COVID are well protected for at least 90 days. So it's not as high of a priority in those groups because they still have natural immunity from the illness. But again, we want to get to those folks as well. I can tell you, I've had family members who've had it and asked me the same question. Yes, they should get it, but they probably don't need to be first in line because they're still protected if they're within that 90 days. It's probably, the protection from natural illness is probably longer than that, but that's all we have the evidence for right now.
Councilmember Harper Madison, then Pio.
Thank you, Mayor. Thank you, Dr. Escott and Director Hayden. Most of my questions have been answered, and you probably recall during the course of our conversation, we talked about what I was proposing to ask during the course of the special call for the Health and Human Services Committee. So just acknowledge as I ask whether or not these are questions that I could postpone for the folks from the Office of Medical Director who will probably be able to answer some of these questions, specifically as they pertain to surge concerns and emergency medical personnel capacity. Those are some of my questions. Should you be the one to address those, or later when we get more around emergency services and emergency services personnel concerns?
Councilmember, I have discussed our conversation with Dr. Pickett, who's prepared to provide a response at that time.
Okay, thank you. I appreciate that. In which case, I'll skip to my questions. I know that you acknowledged generally being comfortable with the 25% capacity for PARD facilities, but I'm certain that I'm not the only one who's received repeated questions, concerns from constituents and frankly employees for Barton Springs. I'm wondering if you have received similar concerns and what your stance is there.
I have, and I've also seen photos which have been circulated. The photos that were circulated were from over summer, from the information that I've received from PARD. And again, it is a balancing act between having outdoor space available and open for folks, while also mitigating the risk of congregation. And that's why they're limiting the occupancy. I think PARD's information to us when we met last week was that over the previous week, a maximum of 5% occupancy was all that was realized in the previous week. So again, we'll continue to keep a close eye on that, particularly as the weather changes and it may become more attractive for folks to be out and about. Again, the take-home message for our entire community is we don't want you congregating because that spreads disease. So if you're going to be together with people in your household. Otherwise, separate yourselves in groups from other people that you don't know, particularly if you're doing that without a mask on, so that we can control the spread of disease.
Thank you. I appreciate that. And then, just to sort of take that a step further, an additional concern I have, before we were privy to some of this information, which, no fault to anybody who's presenting currently, I realize that it's a moving target, but before we were privy to this information, myself and some members of the community were looking to activate and, just determine what our assets are. And one of the things we considered in terms of the suite of options we have for assets was volunteer effort. So one of the concerns that arose for me in thinking about volunteers being helpful here is what risk level should we assess for volunteers, people volunteering to administer vaccinations or work sites to administer vaccinations? If I understand correctly, one of the elements that's been sort of providing this opportunity for log jams is data collection and data entry. So I'm concerned about, I have questions about what threat level are volunteers exposed to if they have not fallen into that 1A category or the 1B category that's been vaccinated.
So, Councilmember, I'll start, and then Director Hayden may want to add on. When individuals volunteer as part of the vaccination effort, they become part of 1A. So they are then on the front lines and are qualified for the vaccine. So our intention is to ensure that folks who are staffing those sites as volunteers are offered vaccine in order to protect them.
I appreciate that. I think that's a very important consideration. I think I have two more questions that are definitely for you, and then the ones that I have for Director Hayden, I'll hold until everybody else has had the opportunity to ask theirs, the ones that came before me. So portal questions, would that be Dr. Escott or Director Hayden?
Director Hayden.
Okay, so I'll hold on to that. Infusion Center, I assume also Director Hayden.
I can take Infusion Center, Councilmember.
For the Infusion Center, for people to be considered, what are the qualifications? I haven't quite seen anything that specifically says under these circumstances, this is the protocol for which you're considered as eligible to receive this. So I'm curious about, just want to get some clarity there. And then if you could sort of, I guess, project how many infusion centers you suspect we'll need to have and those zip codes of a sort of high need.
Sure, and what I can do is send your office a list of the inclusion criteria. It is long and relatively complex. In broad strokes, anybody over the age of 65. There's some other categories for individuals outside of the age 65 group, but I can send that to you. So we'll be taking referrals directly from physicians, but also community care and Austin Public Health will be directly reaching out to individuals that we test and who test positive, who fall within those criteria to help actively find individuals and make sure that they're aware of that option. So, you know, if folks get that call, it is a real call. If they have any concern about the validity of that call, they can call and be connected through 311, and we will make sure that they have comfort in having that discussion. But it is free, and we have placed it at a site in order to make it very convenient for our community in East Austin.
Thank you. I appreciate that. I believe all the rest of my questions are for Dr. Hayden. I appreciate your time.
Thank you, Mayor. My question is, do you maintain a list of all the doctors that are out there administering the vaccine? I had just lucky to call my doctor, asked him to put me on the list, and I got my vaccine shot Friday. But if I hadn't called him up, I wouldn't have known that he was one of the ones that were administering the vaccine. And also, I had other people that my constituents that call me up and say, "How did I get mine?" And I said, "Well, I called my doctor," and they said, "Well, they called theirs, and they said they don't know anything about the vaccine." So, can you help me understand what's going on out there about what doctors? Do y'all maintain a list of doctors that receive the vaccine that are administering that?
Councilmember, that is available on the DSHS COVID-19 vaccination website. And I believe there's also a link from our APH COVID-19 website. So that has a list and a map, interactive map. You know, part of the challenge is that we have a relatively small number of providers who have been given vaccine. Last time I checked, it was around 60 to 70 different groups. Physicians' offices, clinics, pharmacies have been provided vaccine out of more than 350. So the map that you see now, the list that you see now, is not even close to all of those who are able to provide vaccine. And again, hopefully, as the supply improves, we'll see more availability out there. For now, what we've asked the state to do and what they've done is to provide large volumes of vaccines to entities like Austin Public Health so that we can vaccinate thousands a day and hopefully give people a place to go to get the vaccine now if they fall in that 1B group.
And also, can you help me understand about, are these doctors that are little small clinics and doctors that are receiving the vaccine, are they just for their clients, or can they just, if they have insurance, can they just call any doctor that's administering that, and also is it up to the doctor itself, or can they take patients that are normally not their clients?
Councilmember, generally speaking, a lot of the the individual clinics and doctors' offices that have received allocation, they're going to reserve for their existing patients. If that particular office received a large allocation, there may be some room to offer them, but by and large, I think they're going to offer to their patients first.
Okay, anything else for Dr. Escott before we let him go to the county? I think they're calling for you. All right, Dr. Escott, again, thank you for everything that you're doing and for the information that you're getting out to everyone. We still have one of the lowest mortality rates in the country among cities, but with this surge that we're seeing right now, we're going to have to really fight to hold on to that position. Allison, did you have something before we left?
For Dr. Hayden, or Director Hayden.
All right, Dr. Escott, thank you. Now back to questions then for Director Hayden. I think Greg, you were next.
Thank you. Director Hayden, first two clarifying questions from your responses to Councilmember Tovo's questions. As you had said that the plan had been 20 million vaccines, but instead we were at 5 million as a country. Is that for December and January combined?
That is the information that we received at the federal level.
Right.
What should have been coming out, yes, and that did not occur.
So it's not each month, but between December and January combined, we were hoping for 20 and we're at 5.
Yes,
that's
absolutely
helpful. Thank you. And then my second clarifying question from what Kathy said was, it sounds like we are trying to see if we can coordinate a central sign up that would work across several of those 100 providers the best we can. Is that what the other cities are trying to do? Are other folks trying to do that? Has anyone else achieved that? Because I've seen that other cities have a centralized sign up, but it's not clear what you're signing up for.
Well, my understanding from my colleagues that I've talked with, those are based upon what they have available to distribute. Now, I'm not going to talk all across Texas, just a few of them. I do understand that Denton County was really signing up and wanting to be a distributor. And so that is a little different because then those partners in Denton County would receive the vaccine from them. So,
but in those, I'm sorry. So in those other cities, people are signing up for the publicly available vaccines, of which there's very few, and so they probably need to be going to that public site, but also to all the private providers as well. It's not actually routing them to these other providers.
Now that's what I've heard from the people I have emailed and text, but I can do a better job of trying to understand and at least send it to the TACHO membership, Texas Association of City and County health officials to determine what's happening with all of the partners.
Mayor, I'm going to politely say we can kind of hear your keyboard a little bit.
Okay, I'm sorry.
No, that's okay. And the Director Hayden, with the 12,000 vaccines that we've gotten, how many of those are we more or less planning on having be distributed to specific groups of vulnerable people versus how much of that 12,000 is going to be available for the people who register starting tomorrow?
I would be giving you probably an estimate. Today at the site, we have the ability to do 1,200. Yesterday, we did 850. Tomorrow, we have the ability to do 2,000. So that would pick up, a significant amount of, yes. However, being a safety net provider, our goal is, even with the process, to be able to get more folks to come in during the week, once we open it up, to get more vulnerable people in through this week for the rest of the week.
So about 4,000 of them really, it's not a public sign up, just really directed to vulnerable populations that we know. And then the next 8,000 would be open to the registration, but the registration, we're really prioritizing vulnerable folks to sign up.
Absolutely. Yes, we are.
Right. And so can you level set expectations for us and for the community, since you'll be opening registration tomorrow? Of the 12,000, 4,000 will have already gone to vulnerable people. It means that people are signing up. And we have 200,000 uninsured folks in the area. We'll have people signing up for 8,000. Can you, we've seen news in other cities where the registration is full within 5 minutes online. We saw with the financial direct assistance phone lines getting overwhelmed immediately. This is an impossible challenge to solve when you only have 8,000 vaccines. But can you help level set expectations for how you all are preparing for this and what the community should know, since it's really important and great for us to do these 12,000 this week, but we know the need is so great. So how are we setting expectations for the community, and what are you preparing for?
Well, ultimately, the goal is to prioritize and to make sure that we are addressing our most vulnerable people in our community. And so, moving forward, the plan is to continue to provide vaccine to our community. But we are going to ask people that they're really going to have to be patient with us. Everyone that wants to get in to the vaccine on Wednesday is not going to be able to get in. That is the reality of it. And so we just ask that you work with us as we're moving through this process, as we have, other conversations, with our colleagues across the region, and really look at, how we could set up a regional approach. But we really need people to really be patient with us as we go through this process. I know it's unfortunate that, so many folks have made calls and have been on calls for an extensive period of time. And that's very, very unfortunate for people to have gone through that. And so, I can say that, I apologize that people have had to do that in our community. But our hope is that people are patient with us, and as we, continue to receive vaccine, and are able to stand up operations even more, collaborating across with other partners. As soon as vaccine becomes available, our partners are ready to provide it. They've emailed me several times, as Dr. Escott has stated before. So our partners are ready to participate and to, provide the vaccine in our community.
Thank you. And we cannot apologize. We shouldn't apologize for trying to administer the small number of vaccines we have. If we were hoping there'd be 20 million produced and there's only 5 million, I think the thing to apologize for would be only if we weren't transparent with that information. We're trying to be transparent. So what I would really urge Austin Public Health to double down and do the best we can. And I know y'all are trying to do some, but my last urging is that we try to be as transparent with everyone about tomorrow and the process going forward as we can. As people make phone calls and they probably hit a voicemail machine because you have so many people who are potentially might call, that we have that voicemail set up to give people the information that there's only a few thousand and there's hundreds of thousands of people that need it. That if on the website we make that really clear about who is most vulnerable and who we really want signing up, and the fact that those folks still there's a good chance you may not get it. But I think if we're transparent, then we can continue to retain the trust that we'll need when we're doing 5 and 7 and 10,000 a day, that we'll need to be able to go tap back into once there is enough supply. So I appreciate all the transparency from these sessions. And I think we just need to tomorrow do everything we can to set those expectations and be transparent, so that when we tell people come back, come re-register again, that people do so. So thank you, Director Hayden.
Paige, and then Allison, and then Ann.
Thank you, Mayor. Director Hayden, there was a slide that talked about the registration, that there would be a website and a phone number. Is that information public yet, or where should we and the public expect to see that? Would it be on social media or through a memo or press release? Where will we get that information?
We will have a press release sent out tomorrow. It is going to provide the information for the website. It is the same website, austintexas.gov/COVID-19. And so the same place where they go to sign up to take a test, there will be a button for them to push to sign up to enroll for the vaccine. We will have that sent out, through all of our media outlets, just to ensure we get the word out.
Okay, that's very helpful. And then Representative Vicki Goodwin had sent a letter at the state level to talk about vaccine distribution. And there was just one part, I'm not sure if there have been any subsequent updates you're familiar with, but it was about the information being provided at the state level wasn't necessarily reflecting what was happening on the ground in every location. Some places were still administering at the 1A level when some others had moved to 1B. Is there any further update? I know that's not your call to make, but it was just trying to see if there was any more information that had come out about that.
Well, I think the takeaway is that from the direction from the state, it is important for us to ensure that the 1A people are taken care of, the vaccines are provided. And so, on the instance that we find others that still need it, we can address that as well through all of the providers. But the state has also given the clear direction that you can also target the 1B. So at this point, 1A or 1B, you can provide it to either of those folks. They wanted you to primarily do 1A, but you can do 1B as well.
Okay, I think that's helpful for the general public to know. And last question, is there any compiled list of which private healthcare providers are able to administer? I know a lot of people are having these questions about if their clinic is being able to give vaccines, or if they've tried to get in line to get vaccines, or where even their clinic is. A lot of us know we're not high up on the priority list health-wise, but still wanted to know, are we planning for March, April? Should we wait longer than that before we even call our private healthcare providers, not to overwhelm them?
Well, the Department of State Health Services does have that on our website, on their website, but we have put it on our website. And what they typically do is that they populate the site after they receive the vaccines. And so there was maybe about 65 or so, between 65 or 70 that have received vaccines. And so you will see that, but there are an additional, 290 or so to 87, doing the math in my head. But basically that will receive vaccines that are eligible and have worked with the state to be a distributor. And so you'll see more of that to come online when more providers start to receive vaccine. And so, we just ask people to really be patient, especially if you are in a process of you as an individual. If you're working at home, you're not interacting with the public, really our hope is that you would allow other people that are working with the public that must leave their homes to be able to provide a service to the public. Please allow them to go first if you can, is what we're really encouraging the public to do.
That's a great message for us all to remember. Thank you, Director.
Thank you, Allison.
Thank you. I think there have been a lot of really good questions, and I think we're all sort of dancing around the similar, and maybe you could just walk us through a very specific example. Constituent reaches out. They are either themselves in the 1B category or they have a parent that's in the 1 category. When do they go to try to use the APH system, which has limited supply? When do they try and use a private provider, which also has limited supply? And if they go to each of those, what are the steps that they take? I don't know if you can talk through that, and it would be super helpful. And I know it'll change over time if we can get something in writing that we can share out, because I think that is the crux of what we're trying to be as transparent as possible given the limited supply. But there is a lack of clarity if people have to try to understand how the public health system works before they can figure out where they get their vaccine. So if we could try to distill that down, that would be great. Maybe you could try here and we could get something, in writing. And again, this is not on you. It's just the configuration of how we deliver healthcare that makes this complicated.
I think what would be helpful, and I can get with the communications team and share with you all the information of who is that 65 or so providers that have already received vaccine. That doesn't mean that they have it anymore, because as soon as people are receiving it, they are making sure they are providing it in the community. Because knowing that this is the snapshot of the providers that have already received the vaccine, then there's another list of folks that have been approved by DSHS that will be able to receive the vaccine. And then knowing that Austin Public Health, as a safety net provider, with like community care, Lone Star Circle of Care, People's Community Clinic, will typically want to focus our vaccine efforts to the most vulnerable people in our community, underinsured and uninsured. And so that is what we, really just kind of have to emphasize and provide that information to you. So that's a starting place. But we know over time, if we're able to see more vaccine to come into our community, that process can open up broader. And so that language can change to reflect, kind of those 3 tiers that I've described to you.
Thank you. I think it's and it's a challenge for folks, as we had with testing, about when they go to APH, when they go to their provider, and clearer that we can be about that, always with the caveat right now that we have limited supply, I think is helpful for communicating and damping down some of the anxiety and helping people to know when they should spend the time on the phone to try to figure it out and when not to. If we can help to communicate that, and it might be one of those decision trees. I remember we had some decision trees at some point over when to go get tested and when to not go to get tested. I think that would be helpful because there are a lot of people who are over 65 who are very anxious to get this, who are not the folks that we are trying to target with APH, and we can help keep them from overwhelming and trying to go to APH if we have clarity over where they should be going or where they could be going, and some, at least most up-to-date expectations about when they can expect to have access to it. Thank you.
With the communications team and ask them to put together something for you all, and we'll send it out via the communication that comes out from the GIST.
Ann, go ahead.
Yes, I'm sorry, Director Hayden, I didn't quite catch what you'll be sending that information out to us. When did you say? I'm sorry, I didn't quite catch it.
As you recall, every day the communication team sends out an update. We will send it through that.
Okay, great. And would that be today or tomorrow, do you think?
Let me get with the team and we can let you know when that will be. I'm going to say not today.
Okay, that's fine. I just want to know when to look for it, and that will be very helpful for us in sending information out and sharing it with constituents. Okay, I have two questions for you. One relates, this circles back around to the conversation about the areas that the health department, our health department will be focusing on in the Eastern Crescent. I think that's good. I think that we need to, be filling in the gaps and focusing on the populations that you've identified. My question is, it's similar to questions that we talked about during testing. I'm wondering if, in PPE distribution, does that include 78744? And if you don't know yet, we can talk about it afterwards. The reason I'm asking is that sometimes, we do have vulnerable areas in the South and other places too. And I'm just wanting to understand what we're talking about when we talk about particular parts of town. So South and Southeast and 78744 is the thinking to include those areas?
Yes, we will. We're going to, the data is going to make the decisions for us. We're looking at where the positivity rate is. We're going to be looking at areas where we see the most community transmission. We're going to be looking at areas where we know that more people of color are living, individuals that have a lower socioeconomic status in our community. And so those are some of the areas, some of the considerations that we are going to keep in mind when we are looking at where to stand up and to provide our vaccines. And that was the same type of thinking we used when we established our testing locations. The other thing, just as an FYI, there may be some locations where we send a strike team out where, we are there like once a month or twice a month or something like that. Because we know, to be honest with you, to be out all over Travis County, because we've got to be working not only with the city of Austin, but we've got to work with smaller cities as well, and seeing how we can have a presence out there with working with the elected officials and community leaders in those areas.
Okay, that's great. I just wanted to clarify, and of course the data will drive just as it did with testing, and that was very helpful. And the reason I brought that up is just because, sometimes we have some areas. I'm most familiar with South Austin. It wouldn't be the only area, but we have some areas and some zip code areas and some neighborhood areas that are low income communities of color, and they may not be. They may be more isolated areas within other districts, for example. And so I was just hoping that you would be looking at the demographics for all parts of town and the data for all parts of town. So it sounds like you're doing that. So that's great. So good. Okay. Then my second question is about the homeless population. And I wanted to say thank you. I appreciate it. I think at one of our, may have been our last briefing or a recent briefing, we had some conversation about keeping the Pearl Lodges open during a pandemic and not closing them down at the end of December. So I appreciated the opportunity to have that conversation, and I'm glad to hear that the city has found a way to continue with our Pro Lodges, and they were not closed, or none of them were closed at the end of December. So I just want to say thank you for that. I do have a specific question, and again, if we need to do this offline because you're not certain, that's fine. But and let me also say I'm very pleased to hear, and I know that everyone's been working very hard to house folks that are staying in the Pro Lodges. So I think you said 131 people have been housed at this point, which is very impressive, and I appreciate all that effort. So my question is, as people that are staying in the Pro Lodges are housed, are we then opening up that room for another homeless person? Are we keeping our pro lodges full?
Since this is an asset for our community, that asset is always open. So it is not a closed process because it is an asset for our community. So it's not even just a matter of that room is free and then we put somebody else in it. We just want to make sure that we keep that asset available in our community. And as you know, all 5 protected lodges are open.
Are they full?
No, they are not full. And staff are working with the providers to identify folks that will be in that space. So right now, no, they are not full.
Okay. Do you know how many, can you just tell us how many people are staying in the pro lodges and how much more room there is?
I would have to get with staff to get that information. I believe a little over 200 people that are still housed there.
Okay, so you can send that separately. So there could be as many as 100 places still open, it sounds like. So that's what I'd like to understand, how many places are still open and the process for filling those places. So thank you. Let's see if I had any other questions. I believe that's it. Thank you very much.
Thank you.
Thank you, colleagues. Anything else for Director Hayden? Kathy, and then Greg. You're muted, Kathy.
That's okay. I'll follow up on that question with Councilmember Kitchen. If you could make sure that we all receive that information, that gap troubles me with the 100 additional beds that we could be availing ourselves of.
Kathy is asking, because you're faint, Kathy's asking for the information that...
Yeah, if you could just make sure, Director Hayden, that we all get that information about our pro lodges. I share what I heard Councilmember Kitchen say. I share an interest in seeing those beds be utilized, since we know there are individuals who could use them. So if we could follow up on how and when that would happen. Thank you.
Director Hayden, I saw a lot of heads nodding during your discussion with Councilmember Alter about being able to give advice to our constituents that are Phase 1B and their family members. I know that advice is going to be changing often, but even if you were able to list like this applies for these 4 days, and then we'll get you an update if any, it could be really helpful. I just saw a lot of agreement there. I know you mentioned that maybe it could come to us in the normal communications email, but it might even need to be something that is more of a flow chart than that, because even just from this presentation, we've already received a bunch of emails from folks saying, if I'm over 65 and I'm on Medicare, that's something I should be signing up for tomorrow? Or if I'm over 65, but I'm completely uninsured and don't even qualify for Medicare, should I do it? Or if I'm somebody on the front lines with a health condition, should I do it? And so I just think that Phase 1B has so many different categories and components that some sort of flow chart that says this is our advice. If you fall into one of these categories about what you should be doing, is it making phone calls to private providers or signing up with the city or doing both? There's just so many questions that the more advice we can give, the better. I think what we've seen from the advice on slowing the spread is that people are willing to make sacrifices and be patient and go the extra mile if we're transparent with the information and tell them, because we're trying to help these folks that need it the most, we're asking you to do X. I think a lot of people will step up and do that, but I don't think that there is that coordinated direction. So this may be just reiterating what Councilmember Alter just asked for, but I think that having that level of details for people that we can give could be really helpful so that people know when to call.
Okay, anything else for Stephanie? Natasha?
Thank you very much. I appreciate it. Director Hayden, so you answered a lot of my questions over the last couple of weeks, but I'm still, as the process continues, other questions arise, and then there aren't any answers for some. So I think you tried to offer some clarity today about the dashboard component, and I just want to make certain that my colleagues understand it that the way I did and that my understanding is accurate. So the way that I understood your explanation of our access to the dashboard was that we were operating in deference to the state's dashboard because they had more information, in which case we were assuming that their dashboard would be more comprehensive and thus more valuable, in which case that's why we were deferring to them to create the dashboard. Is that correct, or did something change there?
Because the state is working directly with the providers.
Right.
They will have every provider that is approved by them, because we all have to use the Imitrex system. All of that data will be on the state's website. What Austin Public Health has access to is our vaccine that we provide and all of the demographic data that comes with that. And so knowing that that website is available, we have the ability to add that to our website by taking information off of that website. I'll give you an example. When Dr. Escott comes and he shows you a map of the state of Texas, which was in his last presentation, that is data that he pulled off of the state website and just put it in one nice place where we can see those 18 areas with the hospitalization rates. So that is just an example. So for us, we will start with Austin Public Health's data, populated with our information, but the goal is to be able to, over time, to add more providers, just as we've done with testing.
Thank you. I appreciate that. And I think I understood correctly. Okay, so these are EMS questions. Pro lodges. I'm really happy to hear. Did I hear correctly? 62 people were housed out of our pro lodges in December?
Yes, yes.
So of the 131 total, minus that 62, what does it look like in terms of our projected timeline for getting the remainder of the folks in our pro lodges housed, and then, being able to get 193 more people in?
Well, I think the thing to really keep in mind is that because this is an asset, and the asset, will remain open, definitely throughout the process of being in the middle of an emergency response. And so as folks are able to connect that individual with a case manager, that case manager starts working with them in the protective lodges, but then that case manager follows them to where they are placed. And so I think that's the other thing that, for the awareness of this group is that person, is following that person and ensuring they have that supportive services once they are housed. We're also working with the City of Austin Housing Authority. We're really excited about the vouchers that they are going to provide us to house some of the folks from the protective lodges. And then veterans have stepped up, and so we've been able to use some of the vast vouchers as well from the Veterans Administration. And so it's been a very collaborative effort.
That's awesome. Thank you. You said the City of Austin Housing Authority. Does that also apply for the Travis County Housing Authority? Do we have a partnership there as well?
We have a partnership there, but they have not provided to us that they have vouchers for us. We'll continue to work with them.
Thank you. I appreciate that. You spoke to the benefits of using Salesforce. You said the portal was live as of the 13th. You've spoken on occasion about us administering testing for COVID-19 in-home for people that are homebound. I don't know that I've heard any conversation around a strategy for in-home delivery of vaccination. Is that an option? Is that a part of our suite of options for distribution?
That is going to be a part of our process. Large sites with the ability to have a huge kind of throughput, small community locations, but then also a few pop-up sites working with some of the other city elected officials in areas within the county, and then at-home testing is our strategy. And then on the regional, having those questions and that conversation about a regional approach as well. So those are all of the options with providing vaccines that we are looking to do.
Are you able to expand on the at-home option any currently? Who's eligible, under what circumstances, how do we find them? Who does the administering of the, because I honestly, I think answering that question might alleviate the question and concern that I have in another area about the use of first responders for distributing vaccinations.
Well, typically, what we've done before is between Austin Public Health staff and one of our vendors. They have been able to provide the at-home testing, and typically we have really focused on senior citizens and or people that have that are disabled, whether it is a younger person that you have in your home that you may have difficulties taking them out to one of the testing sites for various reasons. And so they just typically call 311, work through with our nursing staff, and our nursing staff are able to schedule that in-home testing. We would mirror that process to where we're able to provide that testing at home. We have had conversations with the fire department. Chief Baker has been very gracious. We've had several meetings, and matter of fact, they are helping us this week with our efforts of providing vaccine.
Right, and if I understand that correctly, that's all volunteer. They're not on the clock when they're helping to administer vaccines, or are they on the clock? Is this a paid use of that of AFD staff?
Chief Baker would have to answer that question if they are getting paid.
Okay, thank you. I appreciate that. And I have plenty of questions for those folks, so I can save that. One other question I have about in-home, it comes back to people who are homebound and how we find them. I have some concerns about folks who, let's say, for example, I know that we have a lot of folks who call EMS, I'm sorry, not EMS, they call 911 when they fall, if they can't get up. If there's some situation where they physically cannot help themselves, their response is to call our emergency services. Some of these folks have in-home care, some don't. Some have family members that come on occasion, others don't. That group of people, I think that's one of those clusters of folks that will very easily get forgotten throughout the course of this process, if not for the, let's say, Station 11 or Station 16, Station 23, Station 30, they regularly make calls on people because they fell, because they can't get up, because, I wonder if there's an opportunity for our emergency services personnel to contribute to that sort of running list of, obviously without, bypassing HIPAA or any privacy considerations. They are on the ground and they see the folks who need help, who often aren't getting the help, in which case they're calling 911 to get help. Is there an option within the portal system for them to contribute to us, or maybe a back end portal? I hope you understand what I'm saying. I don't know what the application of it would be, but that's a group of folks I'm concerned about.
I think what would be best is the department work directly with EMS and fire on that and develop what that process would look like so we can ensure that we're able to provide assistance to them if they need vaccine. So we can just take that offline, work with Ernie and his team and Chief Baker to establish a process for people that they have, contact with and have assisted that may have challenges with that are at home. We can do that outside of this process.
I appreciate that. And if, when you all are sending all the information that some of my colleagues have requested that we all receive, if we could be a part of the continuation of that conversation and just, be able to see the resolution of that concern, that would be great. Thank you. I appreciate it. And so outreach efforts is my other question. I know that I have seen some forums, town halls. I just wonder if there's anything remotely akin to, when we partnered for the outreach effort for COVID-19 testing and just information distribution. That pilot sort of has taken on a life of its own and is living, between our economic development department, APH, a couple other entities. I just wonder if now is go time for the continuation of that pilot. And if so, do we have vendors named already for dissemination of information? Do we have a strategy? Is it postcards? Is it door to door? Is it flyers with just information and resources? I'm curious about what the evolution of the outreach process looks like for those, really hard to reach folks.
So that solicitation just closed last week.
Okay.
And those contracts are being evaluated. Once we have an update on that, we can come back to you with that information.
That would be great. And I think that's another one of those things that I think all my colleagues would be grateful to have access to. Okay, so I find myself continually just sort of confused about our MSA/regional/local/hyperlocal approach in terms of the strategy. I think it's safe to assume that folks who are in extremely rural areas who don't have as much access to hospital capacity as we do come to Austin when they need treatment. So I'm confused about what this execution looks like, sometimes what the numbers look like when we're taking into consideration adjacent municipalities and counties. I'm just very, I guess ultimately this isn't a question that you would have to answer today. I'm expressing a concern about our ability to assess and project how quickly, because of those additional considerations of populations of people outside of the Austin area, how quickly Austin-specific facilities will not be able to accommodate people who live within the city limits, and where are those numbers reflected in our reporting? I'm endlessly curious when we start to report about, our numbers. What does that look like for the folks coming in from adjacent municipalities? And I don't know that that's a question for now so much as just an area of concern. I wish I understood better what that looked like.
Well, typically, when we have folks that are not from City of Austin and Travis County, on our dashboard, you'll see with our report, you'll see a larger number. And so the larger number reflects all of the other people that may come to Travis County to be tested. Now with the hospitalizations, that is MSA. So it is picking them up, and that data, displays from an MSA perspective. And so it's actually kind of a hybrid of both, where we are inclusive of MSA data within our dashboard that does have other locations. I mean, other, people that are from Williamson County or et cetera. Some of them are included in our data.
So is that one of those times where our, close partnership with the state takes care of the additional cost burden? Or does that cost burden fall within the city of Austin and our Austin Public Health, our regional public health authority?
Well, I think it's a couple of things to think about. Each of us do receive funding from the state of Texas. So thus far, with our preparedness efforts, we've received funding from the state. They have also received funding from the state. It's going to be the same example with the vaccines. With each of us receiving the vaccine that comes from the state, that is seen just kind of as as vaccines for everyone. And so we typically do collaboratively work as closely as we can. Now, there are efforts where we have interlocal agreements, and we have agreements with a few of the other counties. Like, for example, Williamson County has been using Salesforce, and so we share costs with them. Bastrop County used Salesforce, and we shared those costs. So in instances where we can share the costs with the other municipalities, we have been able to do that as well.
Thank you. I think that's helpful. I may ask at a later date for some sort of visual aid to be able to really walk through the intricacy there with my constituents. I think something visual could be helpful to get them to understand exactly how the process works and, the application of resources. I have received some questions and I have some of my own, but I'll conceptualize what that might look like, and we'll be in touch about that later. Another question I have is about our ISOFAC facilities. I know at one time, there had been, we were ebbing and flowing, and there was a significant ebb, specifically during my time at one of the ISOFAC facilities. I wonder where we are there, and, if we have sufficient capacity and if people are using that resource.
Well, as you all know, we did downsize the current facility we were in. We went to a smaller facility, but because of the increase of cases, we have been in contact with the real estate office to look at and maybe have another facility online, because we want to be prepared if we need to stand up a second isolation facility. So we have seen, because there is an increase of transmissions, we have seen more people utilize the ISOFAC facility.
Just out of curiosity, I recognize, in talking to some of my constituents early on, several months ago, they didn't even realize isolation facility was an option. And now I'm finding that people are more familiar. They know it's available. They're utilizing it, and it's very helpful. And like Councilmember Fuentes pointed out, abuelos living in the house with the whole family, one tia or tío gets sick, and then they get to go to the isolation facility. It's very helpful in isolating the infection. But I just wonder, what do you suppose changed in terms of having more people access the isolation facility, and how do we continue that, whatever it was that initiated, people really utilizing that asset?
Well, our communications team is always improving their communication efforts. We work very closely with grassroots organizations, and we have continuously got the word out about the isolation facility. And so that communications team has done a great job with getting the word out.
Well, I guess we're giving a shout out to the comms team, because I definitely went from, the majority of the constituents that I was interacting with not knowing it was available at all to them asking specifically about it now. So something permeated, and that's really good news, I think. And I'm glad that we're thinking about setting up another operation. Just out of curiosity, in terms of numbers, what does that look like? So I know we had the Crown Plaza. What does the larger facility or additional facility look like in terms of numbers? Is it as big as that one that we downsized from, or one that's comparably sized to the one we moved into? What does the size scale look like?
I don't have that information with me. Okay. I can get that to you at a later date and time. I will make sure it's included in the report that comes out to the group about the isolation capacity this evening.
That'd be very helpful. Thank you. And then I think, look at the state dashboard. The transportation access component, just if we could expand on that some, is that the population that we're talking about being eligible for in-home vaccination, or is there some considerations around mobile vaccination. How are we addressing the transportation access component? It was under the equity considerations.
Yes, typically, all of the facilities that we establish in the Eastern Crescent will be near transportation. So folks, if they need to ride public transportation, it will be easily accessible for them. And so that is in our considerations when we are standing up site.
I understand. Thank you for that clarification. I think my mind went directly to personal transportation as opposed to public transportation. I appreciate that. And then I think Dr. Escott alluded to where we'd be headed with this consideration around administration shift and the impact of that. Do you anticipate that we'll get some sort of report on maybe exactly what the change in administration will look like in terms of how it shifts our vaccination distribution strategy? I'm certain that you guys have taken those things into consideration. I wonder if we will get to see exactly what the rationale is for some of the decisions that are a direct result of the change in administration.
Well, I think what is going to be important for us is to work with our intergovernmental affairs folks, as well as the information that we receive from the Centers for Disease Control. And so as we receive more of that information, we can definitely share that. I'm not sure we're going to be able to do a comparison of what's happening now versus what will happen in the future. So I would recommend that we only focus on what's happening right now as we move forward.
I appreciate that. Thank you very much. I think that's all my questions outside of specific questions for emergency services. Thank you.
Mm-hmm.
Colleagues, we're just about to go to PO, and then I think McKinsey may have raised her hand as well. It is about 15 minutes before noon. I don't know if you want to take a noon break for lunch, and if there are folks that want to come back after lunch. I think there were some public safety related questions that Council Member Harper Madison wanted to raise. So I don't know what your pleasure is. If you want to think about that for a second while we give Pio a chance to ask his question, and then we'll come back to the scheduling thing. Pio, you want to ask your questions quickly here, and then we'll have the scheduling conversation.
Yes, thank you, Mayor. Stephanie, I noticed that there's some of the clinics and health departments that have the vaccine. How are you administering that to the people? Is that one of the places that you recommend them to go when they call, or are you using a list? And should people that do not qualify, do not have insurance, should be calling those numbers there that are posted on the state website, or should they go through another process? Because I've noticed that there's certain locations that have so many doses, and I don't know how y'all reaching out to the folks.
Well, what we have provided on our website is we've provided the locations, the link to DISH's website. The DISH's website shows the 65 or so places that have already received the vaccine. And so we have shared that, and it's on our website. What we have told folks thus far is that we have been focusing in on the 1A with that initial 1,300 vaccines that the department received. And so we're continuing 1A this week. And then with the portal being live on tomorrow, the shift for Thursday, we'll start picking up some of the 1B folks as working, closely with the partners too.
So people could just call that phone number that on the website and get on the list right now, or is it?
So the list is not open right now. They would need to wait until tomorrow. They can go on to the website and sign up like they would for a test. They do not have access to the website. We're just asking them to call 311, and then they will connect them with our staff. Our nursing line also is set up, but it's probably just easy for me to tell them the 311 and they'll get them over to our folks with that process. And our folks can sign them up as well.
Thank you for that information. I was curious, and I really want to thank you for letting us know. And well, I'm sure that everyone is just can't wait till tomorrow so that they can call. And I'm glad that you're making it really convenient by just all they have to do is call 311. So thank you.
Okay. We're going to let Mackenzie ask her question, and then I'm going to ask Councilmember Harper Madison if you have an estimate as how long you think it will take to do the public safety related questions that you have.
Forever.
Mackenzie.
Thank you so much. So my question is related to the isolation facility. As you all know, it's located in District 6, and the plans to open up another isolation facility, if it meets capacity, would also be in District 6. So my concern is related to individuals from across the city. Have we gotten any problems from individuals needing to isolate as far as transportation to the facility goes because of the distance and how far away it is? And what is Austin Public Health doing to get individuals there when they have those problems?
Any concerns that folks have presented with transportation, we have run that through the command site, and we have addressed that with them. Because we typically, we don't want to put them on a bus line, et cetera. So our folks will handle that case by case. There have not been a significant amount of folks that have made a request for transportation, but we do cover that in the event they need it.
Okay, could you give me an example of how it's been handled, just so that I'm aware and the council's aware, and maybe in one instance how transportation was fixed?
Yes, we've worked closely with our EMS community paramedic program to be able to assist us because, as you know, they are able to work with folks that maybe potentially had some level of exposure.
Okay, thank you.
Mm-hmm.
All right, colleagues, it is 10 minutes before noon. I'm going to need to leave at noon. Councilmember Tovo has agreed to take the chair if you want to continue past noon, but we have the question of a lunch break. Leslie?
Yeah, thanks, Steve. I can't stay online, especially not for a period of time that we don't know how long it will be. Natasha, I think you said forever. And I'm wondering if maybe some of the questions you might be able to take offline directly with staff and allow. I wasn't anticipating this work session briefing to go more than the 3 hours it's already gone today, so I'm going to have to drop off. I'm probably not alone, including staff too, because keeping them online for questioning may be eating into their expectations for the day as well. Steve, if you wouldn't mind. I'll be having to drop off at noon.
Okay.
Chair and Councilmember Poole, I certainly appreciate those considerations. Just for background, so it doesn't appear as though I'm being ticketed with the use of our very valuable staff's time. I actually originally requested a special called meeting for Health and Human Services tomorrow. So it wasn't my idea to combine what I was hoping to extract from that meeting tomorrow and this meeting today, but somehow that happened. So now that we're here, I was certainly saying forever in jest. I do believe it would probably be at least a half hour, if not 45 minutes, to get through the questions that I have. And I think once I lay some of those out, which obviously I've already done behind the scenes, some of this information I think needs to be available public facing. I think once I start laying out some of those questions and concerns, my colleagues will realize that us answering those questions and addressing those concerns is of great value and possesses a lot in the way of time sensitivity for us to be as prepared as possible. I don't think it's any less valuable or important than the presentation that we've received thus far In fact, I think they are of equal importance. So I certainly hope, I wish my colleagues could all stick around, but it was never my intention to have everybody be a part of the meeting. I was exclusively looking for myself and the other members of Health and Human Services to be a part of the meeting. So, Chair, I'll say you do with that information what you will.
That makes sense. And I would ask for the questions that some of us may not be able to stay on, if they could also be committed to writing and sent around in one of our memos, that would also be even more helpful, because then we can read them more quickly than sitting through the conversations. It will also help the public understand what the questions were. It's a little more succinct, and it may be able to more specifically target the questions and answers. So thanks very much. I did not know that you had hoped to have a special called meeting. I too wonder why it was collapsed into the larger meeting. Maybe we can have a little clarity around that in the future. Thanks.
Sure.
Okay. And I guess staff can address that question too. Kathy, did you want to say something?
I was just going to say, maybe we could agree to go to 12:30, and that it sounds like that would probably accommodate Councilmember Harper Madison's questions, and I certainly can stay on, and maybe others can as well.
Okay. Allison?
I was just going to suggest that as well. I have an appointment with several of the staff people who may be involved that I made for one to get my questions answered on another matter, and that's also time sensitive in my mind, so I would like to be able to keep that meeting at 1.
Okay. Ann?
Yeah, thank you. And I want to thank Councilmember Harper Madison for her being proactive in setting up the Health and Human Services Committee and bringing this issue up. I appreciate that. So it sounds like what Councilmember Tovo is suggesting might work. We can see.
I think the suggestions of both Councilmember Tovo and Councilmember Alter's standing 1 o'clock meeting are absolutely achievable.
Sounds good. Well, then at this point, then, Kathy, if you're okay, I'll turn the gavel over to you. And maybe you can get into Tasha's questions and see if you can make that 12:30 time. When my deal's over, I'll check back and see if you guys are still online. With that, Kathy, I'll turn it over to you.
Sounds good. Thank you. Were there other questions for Director Hayden before we turn to the emergency services? Other questions? Okay, I don't see any.
Councilmember Tovo, can you move your microphone?
Sure thing. Is that any better? I was just asking if there were other questions that weren't public safety emergency services related before we turn to those. And I don't see any hands. So Councilmember Harper Madison, do you want to start us off? And Director Hayden, thank you so very much for all your tremendous continued work.
I was going to let you all know that I'm just going to remain on the call just in case something else comes up. And so I will remain with the rest of the team. Thank you.
Thank you for that, Director Hayden. We know you have lots of things pressing on you, so thanks for.
I appreciate that, Councilmember Tovo, and just letting you know that the staff is moving over for the public safety conversation. They have been available, and because it was related to COVID, we had thought to do this conversation all together for efficiency's sake. So I wanted to thank Councilmember Harper Madison for bringing the questions to our attention in advance.
Thank you very much, Deputy City Manager.
Councilmember Tovo, we're having a real tough time hearing you. I'm not sure.
Okay. I will continue to try talking right into the microphone. Councilmember Harper Madison, I think our personnel are coming over, but do you want to start asking your questions and we can see?
You bet. And I'll just sort of tee it up. So some of the questions, concerns, consideration arose as a result of my thought process around how we can most effectively utilize the resources that we have available during the course of the rollout of our vaccine distribution strategy. And so obviously firefighters and paramedics came up as assets that we have available to be able to distribute vaccine or administer vaccine. But during the course of that thought process, it also evolved in recognizing that we are having some issues with staffing that I'd like to concern. or to address the concern arose both personally and professionally, recognizing that there was some mandatory overtime that happened with my spouse who worked for the Austin Fire Department, and realizing that he wasn't the only one doing mandatory overtime. So I would like to talk about mandatory overtime with AFD, EMS, and then sort of all of the implications there. Are we prepared for what Dr. Escott describes as the surge? Are we prepared from a staffing perspective? The way that Dr. Escott describes our ability to address our staffing needs under different circumstances. He said that these are industries, emergency services that rely on redundancy, meaning lots of staff and lots of apparatus. If we don't have that extra, because every county and every adjacent municipality is also experiencing the surge, what's our plan? I'd like very much to be able to lay that out and make sure that we are prepared accurately and appropriately. I'd also like to talk through the fact that, I think I know, but I'd like to get an accurate number for how many staff are out at AFD, APD, and EMS for COVID currently, and what are the implications of that many members of our staff being out? How does that affect people who are not out? How does that affect our response times? I'd also like to ask, I guess I'm sort of grouping the questions now, but I have a laundry list of questions, and they almost all pertain to staff. So like personnel considerations, including, I'm curious about the financial implication of mandatory overtime and people getting overtime regardless of rank. That's generally not how it works. Normally we prioritize how we apply the use of overtime because of the pay scale. So I have some concerns and considerations there as well. I have some very specific to EMS questions and concerns. And then one of the big questions that I have is about rapid testing. I know AFD has been administered the ability to rapid test one another, but EMS doesn't have that ability. I have questions about why. I don't understand the rationale there. And then I also have questions about what the plan is to address what feels like an oversight. Maybe it's not. So I'm looking forward to getting clarity there. And if it was in fact an oversight, or we just haven't done it yet, when do we intend to reconcile that? So I'll certainly try not to have my questions last forever, but if we could get most of that answered within the half hour. If there's anything additional, I'll just I'm certain that my colleagues and I will continue this conversation with staff, but that's a really good start for us and for the public. I think I should preface all of that by saying a major issue here, both from testing for COVID-19 and the ability to effectively distribute the vaccine for COVID-19 in our communities, major considerations for me and probably for all of us in our districts will have to be clear and transparent conversation with our constituents. They need to know what's going on. They need to know why, how, who. We, at various stages throughout us addressing this pandemic, we have to some degree lost the trust of communities that rely on us to be able to take all the necessary considerations for their safety, their health, their wellness, their well-being, their quality of life. And I feel entirely, accountable to them to make certain that we are being as transparent as possible. So if I have these questions and concerns, having this conversation in a public forum, I think is a very efficient way to address our constituents' concerns. They can hear directly what the responses are.
Thank you very much, Council Member. And thank you for laying out your questions. I would suggest we take them in batches. And I know Council Member Kelly has some too, and maybe others on the call, other colleagues also may have questions as we go. So why don't we begin, ACM Ariano, if you would start us off, and maybe we can talk about some of the overtime and staffing issues, and then move on to the discussion of testing and vaccines.
Thank you, Councilmember, and thank you, Councilmember Harper Madison, for this opportunity. Hopefully I'm unmuted, yes, to cover as many questions as we can, and certainly very willing to respond after this meeting and in any other venue that you might want to have this conversation. So you did cover a large range of questions and topic areas. I think what I'd like to do is start off with a more broad conversation, and if I could ask Dr. Pickett to talk about kind of what we're doing from a first responder perspective to keep our responders safe, some of those protocols. You talked a little bit about the use of rapid testing, and as you mentioned, fire department is the first out of the gate to be able to use that, and so perhaps Dr. Pickett can talk a little bit how we're moving forward to make that available to the other public safety departments. And then I think you touched as well on the potential of using fire EMS stations as points for distribution of the vaccine. And then either Dr. Pickett or perhaps Director Hayden can address those. So if that could be the first batch, perhaps to lay out the foundation, we can start there.
Thank you, Ray, and council members, thank you for having me here. I want to give you an overview of what we've been doing from the APH and OMD perspective to protect our workers, maintain our current workforce. So our goals here since the beginning of the pandemic is, number one, to protect our employees. But in that also to protect and care for our patients and to not become a danger to them or potential vector for the disease to them, and also to preserve system response capabilities. In that as well, to preserve our hospital capabilities and the local healthcare system, as we understand from EMS, that we have a big part in that as well. We want to provide cutting-edge, scientifically validated, aggressive medical care with compassion. The scientifically validated, aggressive, and compassionate care we've been doing, I want to make sure that we're staying on top of cutting edge. So first is the personal protective equipment, which we have been evaluating throughout the pandemic, the CDC guidelines, which have shifted now and then. We've reviewed the data that is available to us on what the best approach is in order to advise our field providers. What we found was that initially we translated a lot of the CDC guidelines into general guidelines for the medics and let them make a decision based on what they were doing is sort of what level of PPE that they would don. We found that was that led to more deviations from PPE recommendations than we wanted. So we got together between OMD, APH, EMS, Fire, Austin Public Safety Wellness, Travis County Starflight, and the EMS Association and the Fire Association, and developed our PPE guidelines. So we created a standardized approach for all of calls, and then with additional step-ups for certain type of calls. What we found almost immediately was that led to a much better compliance with PPE and a lot fewer questions from the field, a lot less confusion about what it is that they were supposed to do, because it was also supported by the workforce representatives in the form of the associations that also helped with acceptance. We've been evaluating new protective gear. Of course, as this pandemic has unfolded, there have been a number of ideas floated about how we might better protect our providers and our patients with things such as plastic barriers or bags to cover patients, or to isolate patients during certain procedures. We evaluated every idea that we found either on the internet or that was brought to us. We found that there was very little out there new that provided any additional protection for our members. And in these evaluations, we found that a lot of these systems, ideas, and devices would actually increase the risk to our medics and our firefighters. And so we implemented our PPE, but we have not tried any, we have not implemented any of some of these new devices that have just come about since the beginning of the pandemic. Fairly early on, we started using, we implemented Protocol 36. Now, I know that sounds kind of sinister, but it's actually just a call taking and dispatch protocol that is reserved for pandemics. Now, each call type is, when you call 911, is relegated to a certain protocol. So chest pain is protocol 10, difficulty breathing is protocol 6, things like that. So protocol 36, what this does is it serves as essentially a filter. So when a 911 call comes in, then the call taker goes through a number of these questions that are geared towards the fact that we do have an ongoing pandemic currently, and helps us to identify patients that may be suffering from an infectious disease that otherwise wouldn't be clear from other call-taking protocols, and it allows us to appropriately inform the responders as they are responding to make scene. Also, you've probably seen news from other areas where they've modified treatment protocols in one way or another. And I can tell you that we have not modified our patient treatment protocols in any way for respiratory distress, for cardiac arrest, for response units that are initially assigned based on a call. We have not modified any of those. We very thoughtfully looked through all of these potential modifications with the idea that we may be able to do something to reduce exposure to the medics and firefighters and to protect them from unnecessary exposure. What we found is that there was no modification of our protocols that would improve safety, that would help our medics or firefighters, or would do so without a substantial cost in safety to the patient. What we've seen come about from several other areas are things that are frankly harmful to patients, that increase the risk of bad outcomes, and I don't feel that that help that safety. You've probably seen some media traffic from excuse me, apparently Cedar doesn't sit well with me. So you've seen some media traffic such as from LA, where they've modified their cardiac arrest protocols and will attempt resuscitation on scene, and if unsuccessful, will not transport the patient to the hospital. What I can tell you is that that is LA catching up with the rest of the country, because that's something that has been done everywhere for years already. We found through a substantial amount of research that transporting patients who are still in cardiac arrest is almost never helpful to the patient, and leads to risk for injury to our responders, our providers. And so that has been a standard thing for some time. Additionally, you've seen where LA is, this, as it was put out there, rationing oxygen for patients. Again, this is, it's not a rationing, it's simply titrating oxygen to the patient's need. And this is, again, something that we here at Austin Travis County EMS and Austin Fire have done for many years, utilizing this treatment, this essentially medication for patients in a way only when they need it and how they need it. Now, one of our big things that we did early on was stand up the COVID Clinical Consult Line, or the C3L. The goals of this are to bring the right resource, the right time, the first time for the patients. So this started on March 13th, and it is comprised of trained paramedics who get involved with the call-taking process as well. They do not replace or interfere with any of the call-taking or dispatch, but they're able to gain additional information about the patient, about the situation, about what the resource is that they're asking for. We found that many times people call and they're asking about resources for testing, resources for quarantine, or where they can get more information. And the C3L is able to provide that to them over the phone. They've also served as a resource for our city departments, particularly on public safety, so that when a public safety member has a concerning exposure, then they can get some more information and then help to advise them on proper quarantine procedures if necessary, and get them lined up for testing rapidly as well. The C3L also, based on information collected during this call taking, can advise crews on the appropriate PPE to use, So if they have a hint that there is potentially an exposure to infectious disease, then they can help to advise them on ramping up their PPE as well. They've also, based on these call indicators, been able to in discussion with the patients or the caller, modify a response based on what they hear during that conversation. And lastly, they also assist with non-transport decision making. Many of the patients who call 911 and have an EMS response do not require a trip to the hospital. And C3L helps to direct them to resources, and also when it is suggested that the patient may not benefit from transport to the hospital, then they can also help the field medics with that decision making to make sure that that is a safe and equitable decision that is made. Now, during this time, since March 13th, our COVID clinical consult line has taken 17,087 consults. This is out a total of 97,767 calls for service. Of those 17,000, we've had 3,800 COVID-19 alerts. So these are calls where we suspected that COVID-19 was at play. We also have had 1,800 clinical consult line initiated non-transports. So these were patients that otherwise may have been taken to the hospital, but were able to be directed to other resources. And so this does a couple of things for us. This helps to, one, more efficiently use our healthcare system here and help to preserve hospital resources. But two, it reduces the amount of time that our medics and first responders can spend with a patient who may be potentially infectious, and thereby reducing their risk. The total 911 calls that the C3L intake, 11% of them result in prevention of an ambulance response or cancellation of an ambulance response. So we can modify the number of responders that are going to calls and therefore reduce the exposure of employees to those patients when it is deemed medically appropriate. Now, the part of our efforts to prevent infection and protect our workforce is vaccination. Of course, as you've seen, there's a lot of vaccine hesitancy out there, even amongst members of the medical community. I'm proud to say that within Austin Travis County EMS, 85% of our employees indicated that they do want the vaccine. And I'm happy to say that we've vaccinated pretty much every one of those. I think we have a few stragglers, but we're pretty much there. Austin Fire Department, also a very high rate of vaccine acceptance. And that is in contrast with data that we have from other areas. There was a nationwide survey performed by the Journal of EMS that indicated that only about 50% of EMS providers would want that. Now, I attribute this high level of acceptance to a great deal of education that has been done by the Office of the Medical Director, Austin Public Health, Austin EMS, Austin Fire Department, Austin Police Department. We came out with a joint statement on vaccine that has not only justification, but addresses a number of frequently asked questions as well as rumors that have been out there that people may hear. We've received a lot of feedback that joint statement was well received, and that was put together by the Office of the Medical Director, Austin Public Health, Austin Travis County EMS, Austin Fire, Austin Police, Travis County Sheriff Office, the Travis County Starflight, Travis County Clinical Performance and Education, and the Austin EMS Association, Austin Fire Association, and Austin Police Association. So all of these organizations got together and endorsed this vaccine statement, and this is to help allay a lot of the fears that our employees may have.
Dr. Pickett.
Yes.
Thank you. This is really great and very dense information. Appreciate the overview. I think it might be helpful at this point if we just pause at this point in your presentation and address questions that might be related to protocol and transport and vaccinations among our public safety folks. Councilmember Harper-Madison, I'll start with you if there are any follow-up questions that you have at this point.
Thank you very much, Councilmember Tovo. It's like you're reading my notepad. Those are my questions. Just sort of when we anticipated any escalation in that Protocol 36, How are we addressing those low acuity patients that don't require transport? It looks like, you said 11% cancellation rate. And I'm assuming that you equate or that you relate that to having that additional layer of consideration and dispatch. But I also wonder, what does that mean for those boots on the ground, for paramedics on the ground, if they are at the dispatch level, and what that kind of looks like in terms of cost benefit analysis. I think Councilmember Tovo might have just really hit the nail on the head when she said this is dense. This is a lot of information. And so my hope today was to be able to ask the questions and, where possible, be able to extract responses and answers. But hopefully this will help to assist you all in compiling information that we can review. Much like, Councilmember Poole pointed out, it would be helpful if all of this information, the questions and the responses, were compiled somewhere in a way that we could access them later. But some of the questions that have arisen for me by way of your presentation thus far have to do with that response, the low acuity response, and then whether or not there have been any shifts in our Protocol 36. And if not to date, do we anticipate that there will be, is a question that I have.
Thank you, Councilmember. Those are excellent questions. So the Protocol 36 has several levels. Level 0 being a surveillance only, and then level 1 up to level 3. Level 3 is where we would consider at the point of call taking, just based on information in Protocol 36, not sending a resource to that patient. We are not at that point yet. As far as our ability to handle calls with our current volumes on the street, I will defer to my colleagues, Chief Brown and Chief Rodriguez, to expound a little bit on that. But as of right now, there has been no discussion of escalating from where we are right now. So calls are still handled. They come in through dispatch. Appropriate units are sent. But then the involvement of the COVID clinical consult line helps us to trim down some of those responses by diverting patients to the resources that are probably more appropriate for them. Now, the advantage of this from the street level, there's a lot of dispatches they never hear because they never occur, and so they don't know that the C3L has headed off some of those calls that otherwise would have gotten a response. The other piece of that is by assisting them with initiating non-transports, then that substantially reduces the amount of time that the EMS providers are involved in that call, and thereby reclaiming some unit hour utilization. So looking at, I don't have data for our system here, but looking at other areas such as Houston, which have implemented telemedicine resources and are helping with this sort of system navigation, they on average reduce the call duration for the unit by 45 minutes. And upon initiation of telemedicine, are able to disposition that call and free the ambulance within 10 minutes. So it's a way to halt the call and get that unit available back, able to reset and get back out there on the street.
Thank you. Councilmember?
Oh no, please go ahead.
I was just going to recognize Deputy City Manager for just a quick minute.
Thank you, Councilmember Tovo, and just a recognition of all the hard work and all the information that is moving forward. Just know that staff is taking note of it, and we certainly will follow up with a sort of a Q&A or a summary of the answers so that everyone is available, has that available to them. Thank you so much.
Yeah, that'll be super valuable. Thank you. Councilmember Harper Madison, and then I'll recognize Councilmember Alter, who also has a question.
Thank you very much, and I'll make the question specific to what we just received, and that had to do with, so you said diverting to more appropriate resources. I did hear you say telemedicine, but is it safe to assume some of those additional resources also include encouraging people to see their general physicians or go to minor emergency, or is that an inaccurate assumption?
Council member, that's a very accurate assumption. We do, in talking with the patient, we find out what resources they have available to them. Of course, so many of our community do not have primary care physicians or do not have transportation to an urgent care or minor emergency center. However, when appropriate, we do recommend that. We go as far as our clinical consult line makes direct contact with the patient's primary care physician when available to discuss our findings and also to coordinate follow-up care.
Thank you. I appreciate that. And then the one other question that I had as a result of what you presented was that scale for Protocol 36. It was a 0 to 3. You didn't quite, and maybe you did not miss it. You didn't indicate where we are on the scale.
We're currently at level 1 right now. So again, this does not lead to an automatic. It does not modify the trucks that are initially assigned to a call based on priority. But since we have the clinical consult line involved, then that's what makes it a level 1. But right now, if you call 911 with a certain complaint, you're going to get whatever resources you would have gotten a year ago.
Okay. And then I guess this is neither here nor there, or maybe it's not the kind of question you can answer. In fact, I will ask this offline. I'm just curious to know what reasons emergency services personnel have for being hesitant to receive the vaccine. I'm very curious about that, but I'll compile that in a list of questions that I'll ask offline. You gave me 85% for EMS. Do you have similar percentages for AFD and APD? Or should I ask those folks particularly?
I don't have those numbers in front of me for AFD or APD.
Okay.
Councilmember Alter.
Thank you, and I'll be fairly quick here. I wanted to thank Councilmember Harper Madison for raising these issues. We had some conversations in the lead up to what was going to be the special called meeting, and I had an opportunity as a consequence to ask some questions in advance. And rather than re-ask the questions that I asked in my meeting this morning from 8 o'clock, I would just ask that staff share answers to my questions that were focused on the staffing challenges for EMS, when we would move to implement new quarantine rules, what the emergency staffing plan is, when are we implementing rapid testing and the impacts on the budget, et cetera. If those would be included in the questions, if you are going to prepare some response. I will just say to my colleagues, we had a lengthy conversation, and I believe that we are in a good place considering the search. I understand we're going to work on improving some of the communications, but I think I just want to say I was satisfied with the answers that I got. I think that you all may want to hear what those answers are as well, and thank you for the staff for spending the time with me.
Thank you. I wonder, Deputy City Manager, if it's useful for council members to submit questions through the Q&A portal for today's meeting. That might be an easy way to have those questions and responses linked up with today's session.
Councilmember Tovo, I think that would be terrific, and that would be a good way to consolidate all the questions so that we can be responsive.
Great. Let's each plan on doing that then as we have questions. Councilmember Harper Madison, others, any more questions for Dr. Pickett, or shall we move on to AFD and APD?
I believe, especially since you just laid some of them out specifically, I believe Councilmember Alter's questions during the course of our meeting and subsequently that she submitted to them answers some of my very specific EMS questions. And a question I do have is, so people are asking, they're sort of clamoring just like they did in the beginning when we were getting folks tested for COVID. People are clamoring to be helpful. And so lots of folks are calling and asking how they can help with the distribution of vaccinations. And so the question there is, it sounds to me as though EMS is eligible, AFD is eligible by way of their paramedic certification. Do people who are retired need to recertify? Are they somehow perpetually eligible? What does that look like with people volunteering to administer vaccinations? Is that not even something that we should consider, and we should move forward and thinking through how they can more appropriately assist with their desire to volunteer around this effort?
Thank you, Councilmember. We, at the Office of the Medical Director, we authorized and credentialed effectively the entire clinical workforce of EMS as well as Austin Fire Department to administer vaccines. So that's overall about 1,700 providers that are authorized and capable of administering a vaccine. So we have not looked into retired personnel assisting with that effort at this time.
Okay, and then another question I have is it comes, well, so if we're thinking that folks are, you spoke at length about PPE provisions and considerations, and it sounds like our emergency personnel aren't contracting COVID-19 on shift or at the station. It sounds to me as though they're contracting COVID-19 in the world, in their daily lives. And so if that's the case, I just wonder if we have any considerations put in place, any encouragement for our emergency services personnel to take extra precautions. I mean, I know that they are autonomous humans, and outside of their work for the city, they don't owe us anything, but we need them to stay well and be healthy. So sorry, it doesn't love me either. And so I'm just curious about what our options are there. How do we keep the folks that we're going to rely on so much, especially during the course of this surge, to stay healthy outside of work? That way they're healthy when we need them to come to work. And that sort of rolls into some of my questions about how many folks are off and what does that look like moving forward?
Thank you, Councilmember. We've echoed the messages from Austin Public Health regarding what all of our community members should be doing right now, which is not gathering in large groups, with isolating appropriately when they are ill, and seeking rapid testing. Our city public safety employees have testing rapidly available to them through Austin Public Safety Wellness. We've also taken advantage of a rapid point of care test for those to help us to determine quarantine need. So whereas the PCR test returns in about 24 to 36 hours, we have a test that once it's run, it just comes back in about 15 minutes. So when we have somebody who gets ill and potentially has exposed an entire fire station, then we can use that rapid test and then very quickly make a determination as to whether or not the others who have been around them have been exposed and therefore would need to quarantine. The rules within our workplaces, of course, we do not allow visitors in stations. We strongly encourage masks. However, one of the barriers that we have is that our firefighters and our EMS providers, when they work 24-hour shifts, they sleep oftentimes in the same bunk room together, and there's not a way that we could find to adequately isolate them from each other if there's not physical space within the station to do that. We looked at trying to set up tents and splitting up those bunk rooms and so forth, but unfortunately we could not find anything that would adequately protect them from that type of an exposure.
Right, which is all the more reason the utmost concerns and considerations around personal safety and protection are so important, because we're not just talking about, exposing the general public. We're talking about you exposing your whole crew. And so I really just have a lot of concerns there. I'm not sure exactly how we address those with us not being able to require vaccination, not being able to require people adhere to any sort of self-implemented quarantine. I know that in my family, we do so for necessary reasons, health reasons and otherwise, but you can't require that of people's families. So I just wanted to express that as a point of concern, because it doesn't sound to me as though it's, crews infecting one another. It's crew members, individual crew members that are making decisions where they get infected and then subsequently are off. Which brings me to sort of that CDC requirement that Councilmember Alter brought up about quarantine requirements by way of CDC recommendation and or requirements, and how that affects our staffing levels. I don't have a question there, just raising that as something that I am questioning. I did have a question about triaging calls, but I think you answered that. The temporary paramedic practitioner that we talked about during the budget process, if I heard this correctly, we only have an interim paramedic practitioner. We don't actually have an FTE in that role. And I just want to know, do you have any idea how quickly, or is there any intention to expedite whatever the HR process is to get that paramedic practitioner in place sooner than later?
Thank you, Councilmember. I'll defer to Councilmember Alter.
Sure.
Thank you, Dr. Pickett. You can speak. I just want to say that's what my 1 o'clock meeting is about, which is why I was so insistent that I wanted to keep it. It was funded in the amendment that I put forward for the Office of the Chief Medical Officer, and the status of that is one of the things that I was trying to check on. If you have information, you're welcome to share it now, Dr. Pickett.
Why don't I just follow up with you after your 1 o'clock? My hope is that it's more comprehensive, and if there are any questions that I get specifically from our constituents, I can share from there. But I think this comprehensive document that we're talking about, the combined document between APH and all the folks who are on the call now, I think will be helpful to answer a lot of these questions and for us to answer our constituents' questions. So thank you, Councilmember Alter. I'll wait until after your 1 o'clock. I only have 2 or 3 other questions, Councilmember Tovo, but I don't want to monopolize the time here. I really wanted to raise the issues, but have my colleagues also be able to answer or ask questions. So if you don't mind, I'll just defer to the end. I have 2 or 3 and they should be easy to answer.
Councilmember, are these about EMS or are they for AFD or APD?
AFD and APD.
Okay, great. And I know Councilmember Kelly has some questions for APD as well. Do we have any last questions? Councilmember Kitchen, do you have a question for APD?
Just a quick one. Yes, just a quick one for EMS. I would just like if you would provide information to our offices about your use of telehealth. I'm very pleased to hear what your experience has been with that. And if you have any background information or anything in writing, I don't want you to have to create a bunch of information, but if you have anything that you can share about what your experience has been and the value of it in terms of results, that would be. Again, I'm not asking you to create anything, but if you have a report or some kind of document that speaks to what you just shared with us in terms of the value of it. I think telehealth is a great tool. I'm very experienced working with it, and I'm very pleased to hear that you all have found it to be useful and are using it. So I know I've talked with EMS over the years a number of times about telehealth. So thank you.
Councilmember Alter, did you also have a question before we move on?
I didn't have a question. I just wanted to remind folks again that in the amendments that we passed in the budget, we made the pandemic hotline permanent. We created conditions for being able to really upgrade what we can do with respect to telehealth by increasing the physicians who can back that up. And then we also took advantage of new billing opportunities that will allow us to do more of that. I think a lot of it is still to be implemented, but we have taken steps in the budget with the work with my amendments and Councilmember Ellis's amendments to do that, moving forward.
Great. Thanks for that reminder and for the work, colleagues, on that policy front. Why don't we move on? And Dr. Pickett, did you have any last pieces of information that we haven't covered yet, or?
Yes, Councilmember, thank you. And this is to one of the questions from Councilmember Harper Madison. So you'd asked about post-exposure quarantine procedure, and you're absolutely right. Most of the exposures and infections that our employees are getting are outside of work from household type exposures. Because we're pretty solid on the PPE, I don't think we're catching it from patients. We're catching it at home, or then possibly within the station. We've got several people that are cohabitating together or riding around in a truck within a couple of feet of each other for hours at a time. However, the post-exposure, post-high risk exposure, the standard procedure still is to quarantine that patient for a period of 10 days post-exposure. And we early on, several months ago, because we have access to these rapid tests, we decided to push that up based on data that we had from the test sensitivity to where we could perform a rapid test at 7 days post-exposure and then return that employee to work a few days earlier. Now, as we're in this widespread spread, the CDC still has not modified their quarantine recommendations unless you are in a critical staffing position, and then you are at that point accepting some amount of risk by modifying those. So we're implementing this new procedure for our employees who are fully vaccinated, or at least have received the first dose of vaccine 2 weeks ago. Because looking at the curves, it's about 2 weeks after that first vaccine shot that you really seem to have a very high level of protection from the virus. That we're not quarantining folks who have a high-risk exposure, whether at home or at work, but we're having them continue to work so long as they're monitoring for symptoms, performing the rapid point-of-care tests at the beginning of their shifts, and also taking certain steps such as not eating together and staying separate from others and making sure that they're wearing the masks. The data that we have right now on the vaccines shows that it prevents a symptomatic case of the disease. We do not have data that shows that it prevents you from becoming an asymptomatic carrier of the disease. Now, we think that that's logical based on other vaccines with a similar level of efficacy, like measles and polio vaccines, but we just don't have that definitive answer right now, and the CDC has come out and said as much. So we can't say definitively, yeah, if you're vaccinated, you can't possibly spread it to other people. So that this is taken us a bit of time because we've rolled in our infectious disease experts to get their opinion on it and reviewed available literature and so forth. So with this new quarantine procedure for folks who are vaccinated, we are making certain assumptions that we don't yet have proven by science. But because we need to protect our ability to respond in our workforce from working conditions which are incredibly difficult, we believe that this process is one that is that's several layers of safety to try to prevent them from spreading it to each other.
Councilmember Harper-Madison.
Just quickly, can you elaborate on what quantifies sort of emergency staffing levels? I heard at some point that we were in the 30s, and I know that given, what the amount of employees we have at EMS, 30 seems like a lot of people to be off. So when do we reach that critical level?
I'll defer to Chief Brown to answer that.
Thank you.
Good afternoon, Council. Jasper Brown, Chief of Staff, Austin Travis County EMS. We have 4 levels of our staffing plan. 4 is our default normal operations. We are currently in level 3. We are looking and at possibly moving to level 2, which would be the next stage of our staffing plan. And within the staffing plan, and I'll send out to Council, I sent it earlier this morning to Councilmember Alter. It lists the things within each step that we can trigger and do if we need to. So, for example, in level 2, we would, cancel all vacations that are already planned for our medics. Currently, we have not done that. We would move all of our admin staffing from our admin support back out to the field. With that comes, risk in those areas that they are currently staffed at. We have our medics in our safety office, in our PIO office, in our continuing education and training, and those all come with a weighing of the risk of moving the staff out. So right now, we have about 30 folks off of the schedule, but some of that's due to COVID and some of it's due to regular sick call and FMLA and other things. So we're kind of teetering on that line of moving to our next step. We still have what we would call our disaster level, which would be our level 1. and everything would get recalled. Everything, we would go to alternate shift patterns of either a 24 on, 24 off, or a 12 on, 12 off type situation. We're not there yet, and we're trying to do everything we can to stay away from that, because that is a huge impact to our workforce life, and we don't want to do that, to go in it for a week and then come out of it for a week. So with the alternate testing and quarantine guidelines that were just sent out on Saturday to us, we've just received some of the rapid testing on Friday from the Office of the Medical Director, and we've requested others from the state, which we'll get through the Austin Fire Department. We believe we'll be able to get back in and helped our schedule immensely. We've also moved a few of our staff, not completely under our staffing plan, but a few of our admin staff where we could squeeze them back out to the field. We have done that just to help bolster the staffing and not have to go to additional overtime that is not already planned for the medics in the field.
And if I may, just to really express my concern there, it is obviously about overtime, that, that there's always a cost to everything, right? And overtime is a cost that we incur as a municipality. But my other concern was about quality of life for our professionals. You can only work so much before you need a break. And so I just want to make certain, obviously that's a point of concern for you all, but I just want to make sure to, flag that as a concern for me. I want to make certain that we're taking care of the people who are taking care of us.
Yes, ma'am, and that's our concern also. When we talk about overtime, we have a overtime list, because we do not keep people over from one shift to another or holding them over from a shift. So they plan their overtime in advance. And so on one of their 3 days off, their second day, they're up for overtime. And we have about 10 to 12 people on overtime every day that we can utilize. We've had occasions where we had to do some callbacks to try to find people to help cover, but we don't hold people over from one shift to another and have them work 48 hours or anything else like that. They all have time off before they have to come back in. We try to utilize those lists that our medics have already known about well in advance, that they may have to come in for the day. On those days, we pay them on-call pay to be ready to come in. And so those are the lists we utilize when necessary. We have had a couple of times over the last 30 days had to, like I said, do some searching and digging for some folks off duty, and then ask some admin folks to go cover some trucks and things like that. But we've been able to keep our units up and staffed.
Thank you. I appreciate that. The one other question I would have as a result of what you just said was about rapid testing. You said y'all got some from the state, some from AFD. How soon do you anticipate y'all having as many as you need?
So we received from OMD about 800 tests, and our source from the state will be through AFD. We're not doing a separate sourcing. We request through the EOC. We're going to start rolling those out in our expanded or modified quarantine rules first, and then also in any meetings or anything else like that. We'll look at moving road as we secure our lines of the testing to see what we do for the entire staff daily testing at shift startup. But we're also, a lot of our folks are now either getting their second shot of the Pfizer, which and then we're about 2 weeks away from staff getting their second shot of the Moderna. So we'll be, in a different place in about 2 weeks.
Thank you.
Thank you so much. Why don't we move on to APD, questions for APD, where it's at 12:45, so we clearly went beyond our 30 minutes. Why don't we start about 1 o'clock and then determine whether it makes sense to take a 30-minute break and come back, or if we're concluded for the day. Councilmember Kelly.
Yes, so my question specifically is for APD, and it's in regards to the isolation facility and the pro lodges and the convention center and expected staffing. But also, while I was visiting the ISOFAC on Saturday, I recognized that there were 2 police officers stationed there, and I've gotten questions from the community as to why it requires 2 officers at all times. I'm hoping maybe you could explain that, and thank you very much.
Yes, good afternoon, Councilmember Kelly. So the reason why there would be 2 is typically with any security assignment we would do with a police officer, we do not leave them there on their own. We typically would want them to have a second officer with them. The reason they're there is that there's a possibility there might be a need for some type of action by the officer to maintain security, and this would allow them to have a backup officer with them in that moment so that they wouldn't be on their own until on-duty officers got there.
Okay, thank you. What is our expected staffing for the alternate care site at the convention center and also for the pro lodges around the city?
I can't speak for the convention center just yet. Obviously, I'm aware that opened up this morning, and I'll get you specifics on what that footprint looks like. The convention center has their own security services that they have, and then they also contract with Texas Department of Public Safety for overtime officers. And so the expectation is that they would be handling the majority of that. But I will confirm and make sure that we share that information with you, as well as what we would need for any other ISOFAC or Pro Lodge facilities that were to open.
Thank you for that. I do have one last question, and it is just with any sort of non-compliance your officers may have been seeing in the public regarding the health advisories that are coming out about COVID. Do you have any examples of what the officers have seen and ways that we might be able to correct that moving forward?
Are you referencing public safety standards like wearing masks and adhering to certain time restrictions, businesses? Yes. So we are really focused on the public education portion of these safety standards that are being issued either through the governor's office or through our local leaders here. And we have partnered with both code enforcement as well as the fire department EMS through our efforts to enforce the restrictions that are put in place, whether it was the temporary restrictions on the allowable hours for food service during the New Year's Eve timeframe, or whether it's the enforcement of the social distancing and the masking. So we respond on a mostly complaint basis if we get calls, but officers proactively can also remind individuals of that need for them to follow the safety guidelines that are out there. We do have some statistics on citations. They're very minimal at this point. We've been successful to the extent we can through public education and through requesting people either mask when we get those calls or come upon that.
Thank you very much, and thank you to the officers who are out there on the front lines working for us.
Thank you.
Other questions for Chief Manley? Councilmember Harper Madison.
Good afternoon, Chief Manley. I'm happy to see that you've recovered well. I have similar questions for you that I had for EMS generally around protocol. I haven't heard anything about PPE protocol for PD. I have seen lots of images, oftentimes provided by our constituents, but just some on television during interviews and otherwise of uniformed officers not wearing masks. I want to know, is there some increased protocol around PPE expectation for our officers to wear masks? And will that, and has that rather increased given our surge status?
Good afternoon, Councilmember, and thank you for your well wishes. The expectation is that our officers wear their mask when they're interacting with each other, interacting with the public, just as we expect everyone else to do. You may see an officer, if they're alone in their vehicle, not wearing a mask, just as we see citizens all the time doing the same. But when they are out in the community interacting, the expectation is that they will wear their mask. I will say when you see officers doing media interviews, myself likewise did one last week, I will wear the mask all the way up to when I get to the media, and then I'll take it off while I speak to the media because we are distanced appropriately and nobody is within that perimeter, and it just allows for easier communication. But specific to your question, the expectation is that officers will be wearing their masks.
And this is actually not for you so much as I'd like to talk to folks in the media. One of my concerns is about shared microphone use. And so that's why when I see folks doing media interviews with a mic that I know other folks have used, I don't know what the protocol is around sanitation and, considerations for protection there with the mics. And so that's just so you know, that's something that's on my mind. But yeah, I had received some photographs from constituents of officers talking to the general public without masks. But it's good to know that that expectation is in place. And I'm certain that between you and APA that there's probably a regular reminder about compliance with wearing necessary PPE when dealing with the general public. And that sort of rolls me into quarantine protocol. I know they talked about Protocol 36 for EMS. Is there something similar in place for for APD?
So we're following the protocol guidelines that are coming from the Health and Wellness Division. And if we have officers that have been exposed, then they'll reach out to the medical branch and determine if that's a legitimate exposure that requires an immediate quarantining, or whether that's a lower risk exposure requires them to self-monitor their condition, as well as if someone in your household becomes infected with COVID. So we've got multiple different layers, but everything flows through the Health and Wellness Division. And then officers, if they are a high-risk exposure, then they will be quarantined in their home until, again, the medical branch clears them to return to work. We've taken the additional steps of trying to reduce unnecessary contacts within the department. We don't obviously have to share the same sleeping spaces and all of that because we don't work 24-hour shifts. But what we've done now as we've moved into these higher stages is we have, again, canceled all show-up briefings. When officers typically come on duty, they'll all sit in the room together and they'll get a pre-shift briefing. That's all either now being done outdoors and spread out or over the computer as they all get in their cars and start their shift. So we're taking those steps that we can internally to minimize any unnecessary contact. And I do have Rick Randall, who is the director over our wellness division here at the police department, who is linked in with all of the other public safety personnel in that health and wellness area that can give follow-up if you want more specifics on the rules regarding when we quarantine and when we do not.
Thank you. I appreciate that. And I think just in the interest of time, if you all could compile that information in something written that includes, so as you talked about Health and Wellness Division being able to clear officers, what does that mean? Is that akin to EMS and, you know, the original 10 days or the modified 7 days? How long is that clearance process? Also, how many officers are off currently? I think I have a general idea for AFD and for EMS, but I'd like to know how many officers are off for APD, what the impact is on personnel and staffing requirements and needs. Then I'd also like to know, do you all have access to rapid test, or is that only available to AFD and EMS because of their paramedic status?
Sure. So let me answer a few of those. The rapid testing is just now being discussed for the potential use at APD. We currently do not have the ability to do the rapid testing, but that actually came up on our executive staff meeting yesterday morning. So that is being discussed of whether or not we would have access to that, and if so, how we would use it. I currently have 59 officers, commissioned personnel that are under quarantine of one form or another right now, along with 15 civilians. And we are, again, given that we're not working in such close proximity on a shift such as like a firehouse or an EMS station, ours typically end up getting spread across the entire organization. We have had a few circumstances where we have had multiple officers on one shift have to be quarantined at once, 3, 4, or 5. And that requires a little bit of an additional shift of resources versus just having 1 or 2 in one sector that is now on quarantine. It was well reported many months back that our last graduating cadet class that graduated in October, that twice we had to put the entire class into a quarantine because of exposures. So outside of a specific incident like that, our exposures have been pretty much across the department, and we've been able to maintain it with making staffing adjustments or overtime hires to cover that.
Thank you. I appreciate all that. I think some of my other questions I can put in written form. One other question I had, I think it's generally across the board. I know that you all don't have a class going right now, but AFD does have a class going right now. So this is an AFD question. Thank you, Chief. I think that's all I had to ask for now. I appreciate your time.
Absolutely.
Councilmember Tovo, I think the last 4 questions I have are AFD specific.
Great. And I see the mayor's back, so I'll turn the chair back over to the mayor. I'm not sure, Mayor, if anyone else has questions for Chief Manley before we move on to the fire department.
Okay. Kathy, thank you for doing that. Paige.
Mine's not a question, but I do have a 1 o'clock I will need to step off for. I will try to come back after that. And I know Councilmember Alter said she also had a 1 o'clock. So if I disappear and come back, that's why.
Okay, thank you. Thank you. Allison?
I just want to flag that my 1 o'clock is with Ray and Nuria and was very difficult to schedule and is about related topics because it has to do with the medical officer, and would very much like to still keep that. I don't think any of us were planning that we were going to be here past 12 today, let alone up to 1. I understand these are important questions. I just wanted to flag that.
Sorry. Well, it doesn't look like there are any further questions then with respect to this. That would get us to fire. Natasha, you want to go ahead and ask your questions? I understand people will need to drop off. But Natasha, why don't you go ahead and at least you're able to air in a public forum these questions?
Thank you. I appreciate that. And if I could just reiterate, it was my intention to have a full 2 hours. So I'm doing my best to condense and be brief. And I appreciate everybody's patience. I'll start with that last question. And this is specifically for FD. I know that there's a current class happening. And so just have some questions about whether or not they've been vaccinated. And if we've had any trouble with quarantine with the current AFD cadet class.
And is it okay to let Chief Manley go?
Absolutely. I don't have any questions for anybody at this point except fire.
Okay. Chief, thank you for being with us.
Thank you, Mayor. Thank you all.
Councilmember Madison Harper, I'm not sure. Hold on, I'm going to pause and let Chief Byers see can you answer that question. I think the only time we had quarantine with recruit class was the same time the APD did. So that's around September, October, if I'm not mistaken. Chief Byers, do you have any additional information for quarantine and whether or not those spy cadets have received their vaccination?
No, sir. I don't have additional information on that.
Okay. We'll find out before we got this call. We can contact the training center and see whether or not those spy cadets had any vaccination. I just don't recall right now. We have so far as of to date, we have had approximately 50% of our members who have been vaccinated with the vaccine as of today. But we'll find out about the spy cadets. I'm just not sure if they're part of that 50 percentile number.
That would be good information to have, because if I have it on good information, they're working out of fire stations on occasion as a part of their training.
They are not working out of fire station right now as part of their training.
So they're not going to fire stations as a part of the training.
And that's not right now. They are. They will be, but as of to date, they have not. But we'll have the number for you here shortly. We're going to go ahead and contact the training department and we can find out in Madison.
I have that information now, Chief. We do have 16 cadets in training, and they have all been vaccinated.
They have been vaccinated. Okay. They have not been in the fire station in the training as of they have they, or have they?
They did. They were at the fire stations for a part of their EMT certification, doing the ride-outs.
Okay.
That is already passed.
Okay.
So they're now onto the fire training.
Okay.
Thank you very much. I appreciate that. And then, so I also have some additional questions very similar to those that I asked of the EMS about protocols, protections. Do we have some systems in place to make certain that we're, addressing not having to go back into that mandatory overtime? I know EMS doesn't have it to where you roll over into an overtime shift after you're 24, but I know fire does have it to where you can roll into an overtime shift after you're 24. And so I just want to know where we are there. That seems like sort of red button level. And so I just want to make certain that we are fully prepared to address our staffing needs.
Absolutely. We still require our members to work mandatory overtime. Once we have exceeded the people who have signed up for overtime, we have a automatic sign up list where the members sign up to volunteer to work overtime. But if we need additional personnel, we will hold those members over for the additional 24 hours.
I met my team just the other day, and our goal is not to make anyone work over 72 hours of overtime. And I think we have had a couple of members who have volunteered to work 72 hours, but we have just recently working on changing that policy to make sure we try to take care of our members, to protect them from being so fatigued from working a 24, 48-hour shift. So to answer your question, we do require a mandatory 48-hour, a mandatory overtime as needed. We have, as of today, had some members, I don't have that exact number, who have worked mandatory overtime. I don't have that number before me, but we have had members to work mandatory overtime.
Thank you. I think all that information will be helpful when we get this compilation of information for myself and my colleagues, information about, how we're utilizing overtime as an asset. Again, just budgetary considerations. When you have lieutenants and above working overtime, there are implications financially about that. And so I'd like to know more specifically about the impact financially to the city for those overtime considerations. I also had questions about us utilizing firefighters to administer vaccinations. Chief Baker, I know that you and I have had this conversation, and we don't, with the sort of abbreviated time that we have, it would be helpful if you and your team could compile some information about what that strategy would look like. Have you had opportunities to talk to and work with APH to sort of see when we would deploy that? I know that they said this week that location was worked by AFD to administer those, I think they said 800 vaccines. I would like to know whether or not that's folks being paid to do so. So when they volunteer, is it them volunteering to be paid to administer vaccines, or is it their personal time? I guess another question around quarantine. Is the protocol the same for AFD as it is for EMS? It sounds like it's totally different for APD. So just wanting to see sort of how closely akin everybody's protocol is. It would be great, I think, if there was a unilateral application of protocol, but I would like to know what each department has in place for protocol for quarantine after exposure.
Absolutely. There may be some deviations for quarantine protocol with fire and APD. I'm not sure because our different work schedule. Fire and EMS working 24 hour, fire working 24-hour shifts. So there may be some deviation, but we would try to get as close as possible. We'll meet with the medical director to make sure we're all following the standard protocol as much as possible. Now, as far as overtime for vaccination or the members given vaccine, we are paying overtime for our members to work with Austin Public Health to get those vaccination. I think right now we're working, if I'm not mistaken, at the Delco Center. I think we have between 15 to 35 files working overtime to administer vaccination. I can get that number to be exact and how many days they will be working. But to answer your question, those members are being paid overtime to administer vaccine. They're not doing it voluntarily for free.
Thank you. I appreciate that. And if we could just get some information included in, real specific information, if and when we go to the strategy of utilizing fire stations, what does that look like? Do people walk up? Do they make an appointment? Are we doing, sort of localized community vaccinations to where we're going door to door? I'm obviously just throwing things out there, but because I don't know. I have no idea what the application of that would be. And I'd like very much to know, and for my colleagues to know also.
Absolutely.
And so if we can get that in writing, you don't have to answer that today. Again, we're sort of short on time. And
Sure. Absolutely.
Thank you. I appreciate it. I think everything else I could probably ask offline. I have some questions about dispatch. Yeah, I think the remainder of my questions I could ask offline.
Sure. Thank you.
Thank you very much. I appreciate y'all's time.
Does anybody else have any questions? With that, are we okay with ending the work session here today? Kathy, again, thank you. So here at 1:04 then, let's go ahead and adjourn the City Council special call meeting.
I know that you always were the only one at the table and behind the door. I know what if every moment was something we could keep? Always had tomorrow to hold you while you sleep. It's gonna get better. You